third one. A 28-year-old with psoriasis is started on TNF alpha inhibitor for severe plaque psoriasis. After 6 weeks of therapy, he develops painful erosions over the dorsum of the hands with purulent drainage. Gram stain shows branching gram-positive filaments. Which organism is most likely? Move on to the next one. A 19-year-old woman presents with widespread vesicles and erosions following unprotected sexual contact. She denies systemic symptoms. Direct fluorescent antibody testing is positive. Which antiviral agent has the most robust evidence for reducing the viral shedding in the acute episode? A 67-year-old male with history of melanoma where BRAF3 where BRAF V600E mutant and Breslow thickness is 2.8 mm, stage 2nd B, is enrolled in an adjuvant therapy trial. The trial investigations checkpoint inhibitor monotherapy versus BRAF and MEK inhibition. So based on the current evidence, which statement is most accurate? On histopathology of a skin biopsy from a patient with suspected systemic sclerosis, you observe homogeneous sclerosis of collagen bundles in the dermis with loss of normal collagen architecture and entrapment of dermal appendages. Which pattern of collagen deposition is being described? A 41-year-old woman with lupus nephritis develops urticarial lesions that persist for more than 24 hours with associated burning sensation and leave post-inflammatory hyperpigmentation. Which term best describes these lesions? A 35-year-old man with recurring genital ulcers, oral ulcers, and recurrent uveitis is evaluated for Behçet's disease. The pathology testing is performed by pricking the volar forearm with 25 gauge needle. A positive response would consist of which of the following findings at 24 to 48 hours? A 52-year-old woman with rheumatoid arthritis develops firm, non-tender nodules on the elbow and fingers. Histopathology shows central fibroid necrosis surrounded by palisading histiocytes and fibroblast. Which diagnosis is most likely? The last one. A 60-year-old man with actinic keratosis on the dorsum hand is treated with imiquimod 5% cream daily for 4 weeks. The mechanism of action primarily involves which pathway? So we are done with the preliminary rounds. अभी फाइनल के लिए रुक जाइए. बस ये हाँ.
After the preliminary round of the quiz, the 4 teams that have been selected are Team IGIMS, Dr. Nikhil Sharma, and you have not written the name of your partner. No, I will allow only you alone on the stage. Why you have not mentioned her name? And team from NMCH, Dr. Shivam Bansal, Dr. Rashmi Kumari. Please come forward. Team from AIMS Patna, Dr. Rishabh Shanghai and Dr. Zoya Nasreen. And team from PMCH, Dr. Bhavini and Dr. Soumya. Please come forward. Please come forward, pick up a chit from here and take your seat.
So congratulations all the 4 teams. So we'll start with the final round. It will go as similarly as we did the preliminary ones. I'll give the questions, you'll have 30 seconds to answer, and similarly you'll write the question answers on your paper. That's all. Okay? So there are a set of 20 questions I'll be asking. So shall I start? Every team is ready? You can write your college name and your teammate's name over the paper. And which team do you guys are, like A, B, C, D?
Good morning, everyone. My name is Dr. Shivani Kumari from IGMS, Team A.
Dr. Nikhil Sharma from IGMS, Team A.
Dr. Rashmi from NMCH, Team B.
Dr. Shivam from NMCH Patna.
Dr. Zoya from AIMS Patna, Team C.
Good morning, everyone. I am Dr. Rishabh Sangai from AIMS Patna, Team C.
Good morning, everyone. I am Dr. Soumya Kiran from PMCH Team D.
Dr. Bhavini Rai from PMCH Team D.
Perfect. So I'm starting with the first question. All ready? Yeah. So, a 25-year-old woman with atopic dermatitis is found to have mutations in the FLG gene on the genetic testing. Which of the following best explains the pathophysiological consequence of FLG mutations in atopic dermatitis? A 42-year-old woman presents with symmetric facial erythema and edema over the cheeks and nose that spares the nasolabial folds. She denies sebaceous gland involvement. Which histological finding would be most consistent with rosacea? Vascular type. A 55-year-old man with moderately severe psoriasis is started on secukinumab. After 3 months, he reports worsening of pustular psoriasis on the palms and soles. This paradoxical worsening is most likely mediated by which mechanism? A 38-year-old woman undergoes excision biopsy of a pigmented lesion. Histopathology shows a compound nevus with melanocytes predominantly in the superficial dermis arranged in ill-defined nests. Nuclear enlargement and increased mitotic activity are present. What is the most likely diagnosis? A 48-year-old man with systemic lupus erythematosus develops severe oral ulcers unresponsive to topical corticosteroids and antimalarials. He is prescribed thalidomide 100 mg daily. Which mechanism of action explains thalidomide's efficacy in SLE-related oral ulcers? A 62-year-old woman presents with sudden onset of edema of lips and tongue lasting 6 hours, preceded by a new prescription for an AC inhibitor 2 weeks ago. Which anatomic compartment is primarily affected in angioedema related to AC inhibitor use? A 34-year-old man with solitary 8 nodule on the ear is excised. Histopathology shows a well-circumscribed tumor with cells containing fine cytoplasmic lipid vacuoles arranged in sheets. These are focal myxoid stroma but no significant pleomorphism. Which diagnosis is most likely? A 5-year-old boy with recurrent impetigo caused by Staphylococcus aureus is found to have heterogeneous mutation in IRGM1. Which immune pathway is most directly impaired in this genetic variant? A 52-year-old woman with granulomatous slag skin, cutaneous T-cell lymphoma variant is enrolled in a trial of denylukin diftitox. Which cellular target does this agent exploit? A 41-year-old woman with vitiligo on the face and hands is started on topical crisaborole twice daily. Compared to topical corticosteroid, what is the primary advantage of PDA4 inhibitors in vitiligo? A 36-year-old man with severe plaque psoriasis on conventional therapies is switched to exikizumab. After 3 doses, he achieves PASI score of 75 response. In terms of immunologic mechanism, which IL-17 subset is primarily responsible for early therapeutic response in psoriasis? A 28-year-old woman with systemic sclerosis develops rapid onset of shortness of breath and chest pain. The CT pulmonary angiography rules out pulmonary embolism. Skin biopsy from the chest wall shows thickened collagen bundles with loss of normal dermal fat. Which pathological process is this consistent with? A 29-year-old woman with systemic lupus erythematosus presents with persistent oral ulcers and is started on topical tacrolimus ointment. Which mechanism explains tacrolimus immunosuppressive action in cutaneous lesion lupus? A 44-year-old man presents with solitary firm nodule on the forearm. A histopathology shows well differentiated squamous cells with horn pearls and keratinization without evidence of invasion beyond the basal lamina. The margins were well defined. What is the diagnosis? A 19-year-old woman with severe acne is started on isotretinoin. Before initiating therapy, she must be enrolled in iPledge. Which which adverse effect is isotretinoin most teratogenic for? A 52-year-old man with a history of actinic keratosis undergoes photodynamic therapy with 5-amino avalonic acid and then red light activation. Which cellular compartment is the primary target for photodynamically generated singlet oxygen? A 61-year-old woman with a 30-year history of atopic dermatitis develops large, poorly defined plaques with lichenification and acanthosis nigricans like features on the intertriginous areas. She is found to have cutaneous T-cell lymphoma. Which genetic alteration is most frequently associated with early stage CTCL? A 37-year-old woman presents with depressed pitted scars over the acral surfaces and trunk following severe acne 10 years ago. She is counseled that the histopathology underlying acne scars involved loss of which structural protein? A 48-year-old man with hypertension is started on amlodipine. 6 weeks later, he develops severe gingival hyperplasia and notes similar changes on the shins and forearms. Histopathology shows fibroblast proliferation with collagen deposition. Which mechanism explains this nifedipine-induced gingival hyperplasia? Now the last one. A 39-year-old woman with persistent hand dermatitis is found to have contact sensitivity to nickel. After 6 months of rigorous nickel avoidance, repeat patch testing shows persistent reaction at 48 hours but resolution by 72 hours. Which immunologic event best explains this fading reaction? So we are done with all the questions. You guys gave all your answers? Okay. So kindly give the sheets. So it will take a minute to evaluate, then we'll let you know, okay? You guys can be seated here or you can go back to your seats, okay? So the results are here. So the team that stood third is Team IGMS, Dr. Shivani Kumari and Dr. Nikhil Sharma. So many congratulations, guys. The team that stood second is NMCH Patna, Dr. Shivam Bansal and Dr. Rashmi Kumari. Many congratulations. And the winner team is Patna Medical College and Hospital, Dr. Soumya and Dr. Bhavini. So many congratulations, guys. Thank you.
Good morning, everyone. Now we are going to start our sessions. The fifth session that will be on pilosebaceous disorders. To chair the first session of today, I would like to invite Dr. Ranjit Kumar sir and Dr. Shivani ma'am to chair the first session.
Good morning, everyone. Now I invite Dr. Nikita Singh to see his product of Patna Medical College to present on topic future of acne therapeutics.
Good morning, everyone. Today I am going to present on the topic future of acne therapeutics. But before jumping to the therapeutics, we need to understand the changing concepts in the acne pathogenesis. Everyone is aware of the traditional tetrad of acne pathogenesis, which includes hyperkeratinization, excess sebum production, and colonization of Cutibacterium acne within the sebum-rich environment, finally leading to the activation of innate immunity, leads to release of inflammatory mediators causing erythema, papules, pustules, and nodules. What's new in the acne pathogenesis now? In the traditional concept, the inflammation was said to be the last step, but now it is said that is the first event, and there has been histological evidences showing immune activation which starts before visible acne lesions. Also, the sebocytes, which was earlier only the lipid-producing or sebum-producing cells, is also an immune cell which sense the danger and release cytokines that drive inflammation. Microbiome dysbiosis is another point where there is increase in a certain strain of Cutibacterium acne and also a loss of diversity that promotes the inflammation. altered lipidomics, which is alteration in the quality of sebum and not just the excess sebum, where there is increase in squalene, free fatty acids, decrease in cholesterol ester, and also increase in pro-inflammatory lipids. And lastly, the mTOR IGF-1 metabolic signaling, which also contribute to acne pathogenesis by increasing the sebocyte metabolism, proliferation, lipid synthesis, and keratinocyte proliferation. Thus, acne is just not a disorder of sebum and keratinization, but also now viewed as an immune metabolic microbial disease. Why do we need newer therapies? Because there has been certain challenges in the management, which includes antibiotic resistance. Due to the rising antibiotic resistance, the efficacy has also been reduced. Relapses after the treatment, adult female acne where there is hormonal fluctuations, stress and cosmetic contribute, truncal acne which is difficult to treat due to the location and occlusion, scars that lead to long-term physical and psychological impact, and due to complex regimen and side effects and costs lead to poor adherence as well. And lastly, the overuse of actives causing irritation, disruption of skin barrier and sensitivity. Thus, a new approach in acne therapy includes we have to treat the inflammation first. Early anti-inflammatory therapy has to be the first step. Next, we have to target the sebocytes, not just for reducing the sebum production, but also the sebum metabolism. We have to preserve the microbiome by employing antibiotic stewardship. And lastly, the precision medicine, which is a personalized treatment based on phenotype. Inflammation. We have already discussed the modern concept where there is early inflammation. The interleukin-1 pathway drives the inflammation where immune cells recruitment and tissue damage takes place. Also, the sebocytes release cytokines, not just the lipid producers, finally leading to inflammasome activation that triggers the inflammation and amplifies the skin lesions. Finally leading to the more inflammation and risk of scarring. So early treatment to control inflammation is prime. And so isotretinoin has been reimagined. Earlier it was said that isotretinoin is to be employed only in patients with severe nodulocystic acne or grade 3 acne. But now it is the modern concepts in acne management states that we have to initiate isotretinoin early in low dose regimen in combination therapy with retinoid, benzoyl peroxide, with or without antibiotics that controls the inflammation and prevent acne scar formation, and also there is long-term remission. Next is targeting the sebocytes. Sebocytes are now recognized as lipid producing cells along with immune cells, endocrine cells and cytokine producing cells. Thus targeting sebocytes modifies disease rather than simply reducing the sebum. And by targeting sebocytes, we have to target the sebum metabolism, which can be done by two ways. We can inhibit the fatty acid synthase inhibitors. The drug is danifanstat, and next is the PPAR modulator. Both these target the sebum metabolism. There has been study which include 180 patients with moderate to severe acne who received oral danifanstat of 25, 50 and 75 milligram once daily or placebo for 12 weeks. And at week 12, the median total lesion counts decreased by 53.2%, 61.3% and 53.1% with 25, 50 and 75 respectively, versus only 34.2% with placebo. Thus overall 50 milligram per day showed the most promising signal. Next is the PPAR modulator. This is a nuclear receptor involved in sebocyte differentiation, lipid metabolism, sebum production and inflammatory signaling, making it an emerging therapeutic agent in acne. Phase 2B randomized double-blind control trial was done across 36 centers where 450 patients with moderate to severe acne was randomized to topical N-acetyl GED 050734 level, 5%, 2% or vehicle once daily for 12 weeks. And with the 5% topical agent, they produced 57.1% reduction in total lesion count compared with only roughly 40% with vehicle. Thus, it can be a novel therapeutic target. Thus, with this, we can come to the conclusion that we just not have to just reduce the sebum production, which is a non-specific approach and has a temporary control, but we have to modify the sebocyte metabolism, which target the root cause, restore the metabolic balance with sustained results and improve the skin health. Next is clascoterone, which is the first FDA-approved topical androgen receptor antagonist, which topically blocks the androgen receptor in the sebocytes, decreasing the sebum production, inflammation, and sebocyte activity. There was a need for local hormonal therapy without systemic adverse effects, and thus clascoterone 1% becomes the first therapy to directly target the androgen signaling within the sebocyte. 2 phase 3 randomized double-blind vehicle control trials included 1,440 patients of age 9 and above with moderate to severe facial acne, treated with clascoterone 1% twice daily for 12 weeks, and at week 12, the IGA treatment success was 18.4% versus 9% in trial 25, and 20.3% versus 6.5% trial 26 for clascoterone versus vehicle respectively. Also, the inflammatory lesions decreased by 19.3 and 20 lesions with clascoterone versus only 15.5 and 12.6 with vehicle, while non-inflammatory lesions decreased by 19.4 lesions in both the trials versus only 13 and 10.8 with the vehicle. The clinical role of clascoterone is mainly in the adult female acne, which targets the hormonal driver of acne. Also effective and well tolerated in adolescent patients. We can also use as a maintenance therapy and as combination therapy with benzoyl peroxide, retinoids, or antibiotics. Next is the targeting follicular keratinization. Trifarotene is a precision retinoid therapy which selectively binds to retinoid acid receptor gamma. It targets the gene regulation, normalizing the keratinization, prevent microcomedone formation, reduces inflammation, improves acne on face and trunk. Thus, it becomes the first selective RAR gamma agonist, and it has been developed due to the need for retinoid with improved selectivity and strong truncal efficacy. In 2 pivotal phase 3 trials, trifarotene 0.005% cream once daily produced significantly greater improvement in global assessment score and inflammatory and non-inflammatory lesion counts than vehicle at week 12. In a 52-week study of 453 patients, treatment success progressively increased, reaching 65.1% for facial and roughly 70% for truncal acne at week 52. Thus, it has a good truncal efficacy. Also, in phase 4 START study further demonstrated potential benefits in acne scarring with 55.2% reduction in atrophic scar count versus only 29.9% with vehicle at week 24. Next is targeting the microbiome. By targeting microbiome, we have to keep in mind that we should not disturb the normal flora, where earlier it was in old strategy, we used to kill all the bacteria to dysbiosis, and there was antibiotic resistance and recurrence was there. We have to modulate the microbiome by restoring the healthy microbiota, reducing the inflammation, improves the outcome and prevent recurrence. And these are the emerging microbiome therapies. Number 1 is the nitric oxide releasing agents that releases nitric oxide to reduce Cutibacterium acne, having an anti-inflammatory and anti-biofilm effects. Bacteriophage therapy, the viruses that specifically target acne-causing bacteria, is highly specific with minimal impact on beneficial microbes. Next is probiotics. We have to restore the healthy microbial balance, reduce inflammation and support skin barrier function. Fourth is the postbiotics. These are the bioactive metabolites and molecules from beneficial microbes having anti-inflammatory, immunomodulatory and barrier supportive effect. And lastly, the biofilm inhibitors that enhance penetration of treatment and reduce persistence. Thus, we have to have a balanced approach. We have to maintain a healthy, diverse skin microbiome, and we have to target, the goal has to be target harmful pathogenic bacteria causing acne and disrupt biofilms and virulence, and thus reducing inflammation and lesions. Next is sericycline. It is antibiotic stewardship in practice. Due to the rising antimicrobial resistance, it has been developed as a narrow spectrum tetracycline that targets acne causing bacteria with minimal impact on the gut microbiome and lower risk of resistance. A study was done with where once daily sericycline 1.5 milligram per kg significantly reduced inflammatory and non-inflammatory lesions compared with placebo at week 12 in patients with moderate to severe acne. The clinical role of sarecycline is we employ in moderate inflammatory acne. Patients with GI intolerance, compared to the older tetracycline, it has a better GI tolerability. Long-term antibiotic stewardship that preserves antibiotic efficacy for the future. Thus, by using sarecycline, we target only the acne and protect the gut microbiome. Oral hormonal therapy, spironolactone, is not a new drug, but its position has changed because of the SAFA randomized control trial, in which there was 410 women with persistent acne. Spironolactone 50 mg per day increased to 100 mg per day over 24 weeks, produced significantly greater improvement than placebo, supporting its use as an evidence-based option for women and potentially reducing reliance on prolonged oral antibiotics. It blocks the androgen receptors and results in decrease in sebum production, sebocyte proliferation, reducing inflammation and comedone formation, thus the inflammatory acne lesions. Lastly, the energy-based therapies, which targets the sebaceous gland, also controls the inflammation and prevents acne formation as well as remodeling of the acne. The sebaceous gland is targeted by lasers with different wavelengths and photodynamic therapy. Inflammation is controlled also by the photodynamic therapy. Along with that, LED therapy, radiofrequency ablation, radiofrequency microneedling, and in the acne scar remodeling, the energy used are the MNRF, that is radiofrequency microneedling, fraction lasers, and photodynamic therapy. One by one, the lasers, that is the EV Clear with wavelength 1726 nanometer, targets the sebaceous gland, and the mechanism that it uses is the selective photothermal injury to sebaceous gland, has a high water absorption, and the effects that it creates is the reduce in sebum production, inflammation, and a long-term reduction in acne lesions. Next laser is the diode laser with wavelength 1450 nanometer. It also targets the sebaceous gland, but the mechanism here is water selective thermal heating, causing thermal injury and coagulation of sebaceous glands, and the effect is similar, that is decrease in sebum, sebaceous activity, and inflammatory lesions. Next is inflammation control, which is done by the LED light. The blue LED targets the Cutibacterium acne, and by activation of the endogenous porphyrins in the bacteria, generating reactive oxygen species and bacterial destructions, thus decreasing the bacterial load and decreasing the inflammatory acne. And the red LED directly targets the inflammatory cells and pathways by photobiomodulation, increasing the mitochondrial activity and decreasing the pro-inflammatory cytokines. The effects is decrease in inflammation, erythema, and faster healing. Next is the microneedling radiofrequency, which targets the dermis. The radiofrequency energy delivered through microneedles, controlled thermal coagulation takes place, and collagenesis and elastic remodeling takes place. Thus, the inflammation decrease, collagen increases, improve active acne and acne scars both. Next is fraction laser, that is carbon dioxide laser, erbium YAG laser, also targets the dermal collagen with fractional photothermolysis, creating microthermal treatment zones, stimulate collagen remodeling and tissue regeneration, and the effect is improved skin texture, acne scars, and overall skin quality. The pipeline therapies is the therapies that has been studied but has not been used in the clinical practices. The sebum metabolism that I have discussed earlier is also a pipeline therapy, and along with that, certain vaccines for acne has been studied with gene-based therapies, exosomes, JAK inhibitors, and biomarker guided therapy. Thus, the last take-home message is that acne is a disease of pilosebaceous immune unit and not simply a blocked follicle. Sebocytes have emerged as central therapeutic targets. Antibiotic stewardship is now a cornerstone for acne management. New therapies such as clascoterone, trifarotene represents a shift towards mechanism-based therapy, and the future of acne care lies in precision dermatology, integrating molecular biology, microbiome science, and personalized treatment strategies. Thank you.
Very nice presentation, Dr. Nikita. Any questions from the audience? Thank you.
Thank you, ma'am, for such an informative session. I would request the speaker and chairperson to collect their memento from near the stage. For the next session, I would like to invite Dr. Aditi Snehal and Dr. Smita Prasad to chair the session.
Good morning, everyone. So it's my privilege to invite on stage Dr. Manish Gautam sir, who is Chief Dermatologist at Skin Solution Dermato-Cosmetics and Laser Center and consultant at Apollo Hospital, Navi Mumbai. He is an eminent dermatologist with over 15 years of experience and has held several prestigious positions in IIDville Maharashtra and IIDville National. Also very active in organizing major academic conferences including DERMACON International 2023. So welcome sir, please start your session.
Thank you for the kind invite and the kind introduction as well. And so very good morning to all of you, and this is my third visit to Patna. So in a way I am partially a product of Patna Medical College because my final DNB exams were held here in 2002. So so this is one part, and then I was invited by our respectable Amarkant Jha sir for Mid-Clinicon in 2016, and this is after 10 years, and with the invite of people like Abhishek and Vikas and PK Roy sir, I am here speaking to you all. So can I have a point? Okay. So my topic today is when acne is more than acne, the PMOS connection in 2026. Why? So what's in a name change? What has changed? So just a C has been replaced by M, or no? A polyendocrine metabolic ovarian syndrome, the new name for polycystic ovary syndrome, has been a multi-step global consensus process. So switching out an C for M won't change clinical care on its own, but the change has global implications for healthcare systems, policy and research, and for advancing understanding and treatment of this condition. So you know, it's a common yet historically neglected female condition, affects 1 in 8 women, more than 170 million women globally are affected. 1935, the history being that Steen-Liefenthal syndrome with gynecological disorder, elevated androgen, irregular menstrual periods, abnormal ovulation and infertility. Later on in 1980, there was the influence on metabolism, cardiovascular risk and endocrine function. And then came in the word PCOS, which is inaccurate because it implies pathological ovarian cysts, obscuring diverse endocrine and metabolic features, contributing to delayed diagnosis, fragmented care and stigma. So in 2026, TEED-JH team, years of debate and input for more than 50 organizations and 22,000 participants, came out with the global consensus that PCOS was to be replaced with PMOS. So international guidelines were at least 2 of the following criteria, with oligoannulation, clinical or biochemical hyperandrogenism, polycystic ovaries on ultrasound, or elevated AMH. These are the criteria. And if you look at it, there are the phenotypes, the classical, the oligoannulatory, the classic phenotype, the ovulatory PCOS, and the phenotype D, which is the non-hyperandrogenicity. So PMS is not just an ovarian disease, it's a multi-system endocrine metabolic disorder. So as dermatologists, how do we look at PMS? How does the clinical profile correlate with PMS pathophysiology? So we have acne, patterned hair loss, hirsutism, acanthosis nigricans, cutaneous metabolic and psychiatric features, family history or the environmental influences. We look at PCOS, or now we call it PMS, lean or obese. It's only in females, or the male phenotype is also there. So we look at the evolution, progression over the period of life from adolescent to adult to menopausal and the elderly. So what are the pathogenic pillars of PMS? So we already said the genetic predisposition, lifestyle and environmental factors, neuroendocrine dysregulation, hyperandrogenism, insulin resistance, and we know that adipose tissue is no longer just a tissue, itself is an endocrine organ now. And chronic low-grade inflammation are these factors. So why is it important to know the PMOS pathophysiology? Because there are changing concepts with early diagnosis, targeted treatment, holistic counseling, and we need a multidisciplinary approach for this. So these are the changes, or which we could say the causes where they are there: the dietary habits with high glycemic foods, chronic stress, gut dysbiosis, physical inactivity, sleep disruption, and environmental toxins. And look at this complex picture which shows all the features which are the causes, and these all together is what we see as PMOS. So coming to each of them, genetic, epigenetic and environmental factors, it's a complex genetic disease wherein the genes load the gun and the environment pulls the trigger. So genome-wide associated studies, insulin receptor, insulin gene variable number of tandem repeats. Then there is a family clustering. Identical twins are prone to get PCOS than fraternal twins. Women having a 50% chance to PCOS if their mother or sibling also had PCOS, and male siblings of women with PCOS are more susceptible to developing IR. So we need a prenatal androgen exposure is always there, fetal androgen excess causing adult metabolic dysfunction. And environmental influences we already talked about. And regarding about the acne, I think Dr. Nikita gave a fantastic overview and the things about the updates in the show. That makes it a little easier for me. So we can just go over these factors a little better. So there is a neuroendocrine dysregulation wherein the hypothalamic gonadotropin releasing hormone with overactive kispeptins and neurokinin B and dysregulated GABA signaling increasing AMH which stimulate the GnRH pulsation. So increased pulse frequency of GnRH which leads to the raised levels of LH, and with that there is excess production of ovarian thecal androgens and relative deficiency of FSH. So that is how the polycystic ovarian morphology and oligoovulation, and with that there is also impaired sex steroid feedback on release of GnRH also which contributes. In IR, elevated insulin levels leads to stimulate the ovarian theca cells and suppress the SHBG production and increase bioavailability of free androgens. So hypothalamic HP axis also, because chronic acute stress activates HP axis and increases cortisol which leads to insulin resistance and hyperandrogenism. So this is the slide of the same, and looking at emerging treatments for this, because we won't be going into detail about this, so we'll be moving on to acne. So I just give a overview. The kispeptin based treatments, natural killer 3 receptor antagonist, AMH antagonist and GLP-1 receptor agonists are the ones which will be useful in this condition. Hyperandrogenism, we know the source of androgen being ovarian, adrenal, peripheral tissues including the adipose tissues, as I said. So skin acts as an independent endocrine organ. So androgen receptors on basal layer sebocytes and DHT and testosterone synthesized from adrenal prohormones within the pilosebaceous unit. So this testosterone DHP via 5-alpha reductase, which this will cause the location specific cheeks, forehead, sebaceous gland hypertrophy and sebum production. So terminal hair differentiation in axilla and genital and face, all these factors have to be thought about. And look at this, the skin deep, the pilosebaceous unit goes under siege, and that is how, if you see all these arrows, these are all the areas where it starts activity. Again, the emerging treatments will be topical androgen receptor inhibitor. Clascosterone, it's a 1% cream for acne vulgaris. It's approved since 2020. We don't have it still in India. We are expecting it soon. And a 5% solution AGA, it's on phase 3 trials right now. So artemisinins, which are the repurposed anti-malarial drugs which decrease the androgen levels and target LONP1 in mitochondria. These are again in the pipeline. So looking at hyperandrogenism, you can see in the males, you can see severe acne, females the jawline acne, back acne. So males there are severe acne, early AGA, hypertrichosis, features of metabolic syndrome and insulin resistance are seen in both males and females both. So PMS, just an overview about the clinical implications. So cutaneous manifestations, acne, hyperacne, seborrhea, hirsutism, androgenetic alopecia, acanthosis nigricans, acrocordons, hyperhidrosis, being poor wound healing, PIH and melasma. And the systemic implications we all know: metabolic syndrome, cardiovascular disease, MASLD, that is the metabolic dysfunction associated steatotic liver disease we call it now, OSA or obstructive sleep apnea, reproductive dysfunction, psychological disorder, autoimmune disorders and malignancy. So when we look at all this, now we can move on to acne. It's maybe actually a dermatological entry point to PMOS. So look particularly for adult onset or persistent acne, sudden worsening of previous acne, jawline or lower face, hirsutism, premenstrual pattern hair loss, acanthosis nigricans, menstrual irregularities and obesity. So what is the biggest conceptual change which has come in? So we don't treat the acne in isolation. Think of the patient as androgen excess leading to sebaceous gland activity, follicular inflammation, acne, PIH scarring. We have been doing this, but also think about insulin resistance, hyperinsulinemia, increased androgen bioavailability and increased sebaceous activity as the factors. So the dermatologist can identify the cutaneous phenotype, while metabolic and reproductive risk should be addressed collaboratively with the endocrinologist or the gynecologist. So anti-androgen therapy is becoming more central. So we have already heard a lot about spironolactone by Dr. Nikita. So it will just say that it is useful when acne coexists with hirsutism, androgenic alopecia, menstrual androgenic symptoms. COC means that the combined oral contraceptives, they are a useful option when contraception is desired also and there are no other contraindications. And the most important shift is towards phenotype driven treatment rather than simply escalating antibiotics or isotretinoin. When your acne patient is not responding initially, and if you can't find features also, please consider this as a undercurrent might be there, so that you have to look at PMS as a possibility. And don't forget the metabolic phenotype. The new PMS terminology is deliberately intended to move clinicians away from thinking that this is primary and ovarian cyst disorder. So this international update in 2026 emphasizes metabolic health alongside reproductive and hyperandrogenic manifestations. So in a woman presenting with recalcitrant adult acne plus clinical hyperandrogenism, the dermatologist should consider whether she warrants PMS assessment rather than simply ordering something like a isolated testosterone level. Look at that. So these are some photographs of some acne patients. It's a 22-year-old female with inflammatory papules, pustules and nodules, lower face generally, jawline, chest and upper back. So there are lesions started 4 years ago, multiple treatments running from doctor to doctor, irregular menstrual cycles, 45 to 90 days. This is the patient where you'll start thinking that yes, there is something amiss, and all the features are there. Similarly, look at this. An 18-year-old woman presents with papules and comedons. Onset since puberty, minimal improvement with multiple topicals, menses fairly regular with occasional skipped months. So this is the second possibility. There you might not see so much of a irregular cycle, but when you get a USG, suspicion gives polycystic ovaries. So you have to encourage the lifestyle changes in such patients. So can we rely on the clinical appearance of acne alone? The answer is no. The resistance to conventional acne therapy should raise a red flag for you. Rule of thumb: moderate to severe or treatment resistant acne in women warrants evaluation for hyperandrogenism. An early diagnosis enables targeted intervention, improving both dermatologic and systemic outcomes. Systemic androgen levels may not directly correlate with acne severity, so local androgen activity has to be thought about, which plays a pivotal role. These are the investigations. So you know all the investigations. HOMA-IR is the basic level which you have to sing the standardized IR index. You can always go for the level for hormonal workup. You have to go for free testosterone as early morning, day 2 to 5. So when we think about these things, don't order straight away a battery of tests. Think about what is really needed, because look at the costs on the right side. We have given the cost also so that we know that how much we are puncturing the patient's pockets. So think about it, just go for the hormonal profile which has been given by the lab, you pick it up and just do it. Please look at specifics and go for that. So patients with PMS should not be treated differently from other patients in initial acne care. A 6-month review is needed to decide whether treatment should change. So OC pills, again as I said, it's an anti-androgen effect of COCP, works through estrogen. I'll just skip this because we'll move on. And there are 4 combined OCPs. An Indian study which found ethinyl estradiol with drospirenone as a good alternative to the one with sapropteron acetate with similar efficacy. So metformin again works beautifully in these conditions. In all the particular thing, PMOS, one of the things which has been around for a long time and works. Dose range is 750 to 2000 mg, and a 6-month treatment regimen of metformin can help reduce the prevalence and degree of acne in women with polycystic ovarian. Spironolactone, we already had quite a detailed discussion, so we'll move on. The dose is around 50 to 100 milligram per day. Its use in adolescents with underlying hyperandrogenism has been supported. Myoinositol, I don't know, I would say it's a thing which is more of a addition to the treatment. You have some now combinations of myoinositol with metformin which are useful to a partial extent, but I feel the Delphi consensus endorses myoinositol are effective and well tolerated for acne and hirsutism. Just give me a minute or two please. Okay. And GLP-1 receptor agonist, we have a talk afterwards in the afternoon with this, and especially semaglutide. This is one thing which is a game changer now. It gradually reduces acne severity, hidradenitis suppurativa activity and sebaceous gland activity. So it shows that benefiting inflammatory skin disorders acting by suppressing pro-inflammatory cytokines such as TNF alpha and IL-17. Clascosterone, I already talked about the topical anti-androgen, a promising option where a hormonal component dominates. And perhaps the most exciting area is PMOS plus acne plus PIH. So in the newer approach is treat acne from day 1. Don't think out, and the pigment also from day 1. So don't wait for acne to clear and then treat the pigmentation. So simultaneous treatment is the in thing now. So the evidence supported options we all know about: topical retinoids, azelaic acid, hydroquinone, tranexamic acid, thiamidol, and some peels as well. So now these are the useful clinical pearl from this is that in skin of color, acne treatment itself can become the pigmentary disease. So don't try to do too much of the over treatment in this particular thing, because iatrogenic inflammation can itself worsen PIH. So this I'll just skip. So what are the future directions? On the basis of pathophysiology, gut vaginal microbiome dysbiosis, mitochondrial dysfunction, diagnostic, we need a criteria, then look at the phenotype, metabolic, endocrine features, and you need screening, and biomarkers will be there. Therapeutics, precision medicine will be there, and AI risk prediction. So future precision medicine approaches may allow improved phenotypic classification and more targeted individualized therapies. I'll just skip this. So PMS is a systemic endocrine metabolic disorder. Insulin resistance and hyperandrogenism is central to most dermatologic manifestation. Skin findings often precede systemic diagnosis, and multidisciplinary care is needed. And by looking beneath the surface of acne, hirsutism and alopecia, the modern dermatologist holds the power to initiate multidisciplinary care, preserve the systemic health, and diffuse a cardiometabolic time bomb. And thank you for your kind attention. I am happy to be here, and I would urge, I see a lot of youngsters here, I would urge youngsters to work for the association and join the association at a level so that you can contribute back to the society what is giving, the society is giving to you. And as a part of that, I am contesting this time for the post of Vice President National, and I would request all of you your support here so that we can take this forward. Thank you so much, and thank you for having me here.
Thank you, sir. It was very informative and very nicely explained everything, as the term is new now. Any question from the audience? Sir, I would like to ask something. Yeah. How common is now like the isotretinoin or retinoids not working in your daily practice?
Generally, if there is this, see, they work initially, in this kind of a picture when you're thinking about PMOS or other. If you're talking about regular acne, I still believe that isotretinoin is the gold standard. If the patient is in the category where you can use it, nothing like it. And now I was mentioning again that you start treating acne and PIH together. So something which prevents PIH very fast is initiating isotretinoin early. So don't look at grades of acne, don't try topicals. That is what I believe. If the patient is one who can take up isotretinoin, you can give isotretinoin, so that patient you should start in grade 2 also. Don't have to wait for them. Okay, so that is one thing. So only in patients with PMOS or with the underlying pathology like this, you might see that isotretinoin works temporarily and then the relapse, or you get, you know, the acne shifting. If you have a central level acne, they go down on a little, you start getting jawline acne in some patients. That's where the suspicion comes in that you are having this. But otherwise, I feel isotretinoin, if given, is working very well most of the cases.
And sir, if we diagnose this, so what is your first line? Like what first thing you give after the USG and it has been proven? So
see, I still believe that metformin works very well, and COCs, that is if you can give oral contraceptives, that's really very effective. And most importantly, it works on the features where you want to, you know, even weight reduction, particularly the one with the drosperinone. So that is one which the OCs, they work very well. So this is my approach most of the time, in addition to the therapies. That is more important.
You apply it like in a combination or any one of them, metformin and OCP together?
Or even spironolactone later on, anti-androgen to be substituted. It's generally metformin and OCPs together. It's not a problem. Okay.
Thank you, sir. Thank you.
Thank you so much. Thank you.
Thank you, sir, for such a detailed session. I would request the speaker and the chairpersons to collect their mementos from near the stage. Next, we have a panel discussion for which I would like to invite Dr. Shivani Singh ma'am on the stage.
Good morning, everyone. So we'll be starting with the panel discussion on the topic hidradenitis suppurativa, management, medical, surgical and beyond. So I would like to invite our panelists, Dr. Archana Lokhande ma'am, Dr. Asmita Singh, Dr. Richa Thakur ma'am, Dr. UK Pallavi ma'am, Dr. Shivani ma'am and Dr. Asfi. So we all know that hidradenitis suppurativa is a disease where the patient is psychologically and physically devastated, and till the time it reached to us, it has already staged up and the reversal from that stage is difficult. So before going to the case proper, we'll look about the epidemiology and the diagnosis. So starting with the epidemiology, I would like to ask Dr. Asfi, what is the burden of disease worldwide if we talk about hidradenitis suppurativa?
HS is substantially underdiagnosed in older study like there is prevalence of 0.3 to like 1%, and in newer study in 2024 meta-analysis, it is reported to be between 2 to 2.5%.
So it is rightly said the global prevalence is around 3%, and there is a problem of early diagnosis, that it is very commonly misdiagnosed and neglected because of its location. So my next question is to Dr. Asmita. The early cases of hidradenitis suppurativa are still misdiagnosed, and why is this misattribution still so high?
Because earlier we tend to treat it as a case of simple acne or folliculitis, but we have to see the diagnostic criteria, especially early staging, and if it fulfills all those diagnostic criteria, like you know, the regions where it is localized, the presence of tunnel sinuses, then we should treat it as HS from the onset rather than just giving antibiotics for acne or topicals.
Correctly said. So we have to have a suspicion if a patient is having recurrent folliculosis like lesion or discharging nodules at your groins or axillary or inframammary area. The next question is to Dr. Shivani ma'am. What is the single greatest barrier to early diagnosis of HS?
According to my opinion, single greatest barrier is lack of recognition of early lesion of HS by physicians or primary healthcare providers, and delayed dermatologist referral.
Yes, rightly said. So to summarize the epidemiology, it is the global prevalence of 1 person is seen in HS with a male to female ratio of 1:3, and the peak onset is seen in second and third decade of life. So there is 7 to 10 years of diagnostic delay, and HS is also responsible for psychological effect on patient, where 43% depression rate and 2 times of suicidal risk has been seen. So the primary care screening question we should follow: if the patient is having any kind of furuncle-like lesion, at least 2 outbreaks within last 6 months, we have to consider HS and we have to treat it like HS. So, Dr. Archana ma'am, what is the primary defect and how can you explain the follicular cascade going on?
So the primary defect, earlier it was thought the apocrine gland disorder, but now the focus has been shifted to the follicular pathology. So most important in the follicular cascade is follicular hyperkeratinization or dyskeratosis, which is causing a follicular occlusion at the follicular level. So that occlusion leads to inflammatory cascades at the lower level. So a lot of inflammatory changes are occurring. That's why there is TNF alpha which is raised, and we are using anti-TNF alphas. Interleukin 1, 6 are raised. There is a role of interleukin 23, 17, TH17 pathway which is getting activated. Along with that, that is a inflammatory trigger is there, follicular dysbiosis is there, or rather than dysbiosis, follicular occlusion and the hyperkeratinization, which is leading to the inflammatory cascade in genetically susceptible person with the favorable metabolic environment. It is the gist of the pathology.
Correctly.
And along with that, there is microbial dysbiosis. So all these factors in the presence of hormonal favorable environment, because HS is predominantly found in the female patients. Okay, so smoking, obesity, metabolic syndrome, all are connected in a similar way. So the follicular occlusion is giving rise to those blind boils, which is the first lesion of HS, as we have discussed in the earlier question. Why we are missing HS? Because it is a blind boil. Okay, so it is something that in the last week only a patient had come to me. Patient was worried about that there is something which is palpable. Earlier it was painful. Now it is not painful, but it has still not gone. It typically obese patient, and there is constant friction which is going on, and taken 2-3 courses of antibiotic, but still worried. CBC is normal, ultrasonography is showing some nodular lesion, but that cascade is going on, going on, going on. So unless and until it is, it goes to the surface, it is not identified. To label it as a folliculitis or acne or whatsoever. So that blind boil is originating from the follicular occlusion, which is occurring at the deeper level. Thank you.
Correctly elaborated. So it starts with follicular hyperkeratosis and occlusion, and it tends to and it leads to gland dilatation leading to microcyst formation, and then followed by rupture of the glands, which is releasing keratin, sebum and bacteria. And lastly, there is stimulation of immune system, as you have rightly said, ma'am. Next question is to Richa, ma'am. What happens immunologically if we delay the systemic treatment during early mild phases?
If we delay the treatment, then we'll see majority of the cases they develop into sinuses and later into fistulas, and they lead to scarring. So the earlier we treat the lesion, we'll have the complications less. So
Yes, ma'am, rightly said, because if we leave it as such, it tends to go to the grand zone where the proper treatment is not possible medically. We have to intervene surgically at that point. So what is the concept of window of opportunity? To Dr. Pallavi, ma'am.
We should stop the intervention at earliest. We should treat it with a topical or with a systemic antibiotic in the beginning.
So yes, as we have seen that during the step 1 and step 2, where the initial symptoms of boil or some palpable nodules the patient comes with, we have to think about HS, and that is the period if we intervene, we will stop the progression of disease and will give the better quality of life to the patient. That is more important, because patient here are psychologically also devastated, and they are having some metabolic factors also, like PMOS and any history of smoking and all.
I would just like to add one point. See, window of opportunity is diagnosing a patient at earlier stage, but what makes a difference is a lifestyle modification, which is always underrated. So there may not be features of PMOS predominantly, but there could be like patient is obese, or if not obese, the physical activity, sedentary life, or the lifestyle, getting up late, sleeping. So that also shifts somewhere the hormonal balances in the body. That's what I feel. The physical activity, the friction, the obesity, the sweating. So all those factors need to be taken care of, and emphasize to the patient that this is on the, see, this is a long way ahead. Down the line 10 years, we are going to see this full-fledged picture. But you have the time to improve your life, so do it now. That is the window of opportunity in my.
So rightly pointed that it has to be the multidisciplinary approach, not only medical or surgical treatment, it has to be the lifestyle modification also.
one more thing I like to add, the moment you tell the patient that you have to lose your weight, the next question will be, ma'am, kaise karna hai? Or in that case, usually I tell all my patients to meet a dietitian, because they'll guide you better.
Rightly said, ma'am. And in our previous session, we have also seen the role of some newer GLP-1 analogs also, where we are not able to control our weight with the help of dietary modification or lifestyle modification. We can take the help of that also. So Dr. Asfi, what are the core diagnostic triad of HS?
Basically 3 points should be present, like typical lesion, like deep-seated nodule, but painful, and typical site, intertriginous site like axilla, inframammillary, and perineal, perianal site, and chronicity should be present. Yeah.
So yes, the diagnostic triad of HS is first is lesional morphology, as already explained by Asfi, followed by anatomical location of axillary area, groin, inframammillary and perianal area, and and third is temporal progression, where the recurrence has to be like more. I mean, it is like within 6 months you have 2 or more recurrence of the same lesions of that at particular area. So how do we stage the disease? Dr. Shivani, ma'am.
It is staged by early staging. In stage 1, there are recurrent inflammatory nodules without sinus tract or cicatrization or scarring. And in stage 2, there will be recurrent inflammatory nodule formation with sinus tract formation or cicatrization. And in stage 3, there will be multiple painful inflammatory nodules. There is widespread involvement with interconnected sinuses, sinus tracts, and bridge scarring and pseudo-comedone formation.
Rightly highlighted. Dr. Asmita ma'am, do we have another staging for monitoring the disease?
Yes, and as you've presented on the slide, it is IHS4 staging. And early staging, basically, it clarifies the anatomical aspect of the disease, the structural component of the disease. But the IHS4 staging denotes the inflammatory part of the disease. So as it is there, nodules are given a score of 1, abscesses 2, and draining tunnels 4. And the scoring is, if it is less than 3, it's denoted as mild, 4 to 10 moderate, and more than 11 severe. So by this staging, actually we know that what is the state of the HS at present, rather than just the anatomical part of it, and how to treat the inflammatory component.
So we focused on staging because according to the stage, we can plan our treatment and monitor our treatment response.
Just one point I would like to add, sorry for interrupting.
It's okay, ma'am.
See, staging is for you and me as a physician. What matters more for the patient is DLQI, visual analog score, pain scoring, and just a feeling what I do generally for any disease. If your disease is maximum today and it is considered as 10, then if you are coming in the follow-up, what it is now? So either it is 5, less than 5, more than 5. That gives me a rough idea in patient's language that how much severity of the disease has improved with my treatment or not.
Yes, ma'am. For the psychological perspective, DLQI is important, but then to initiate our treatment on our side, we should be knowing from where we have to start and where we are. So moving on to the case proper. The question is with Dr. Shivani ma'am. So here we are seeing a 24-year-old smoker female with BMI more than 32 presented with the complaint of recurrent painful discharging nodule over both axillary area, and it is lasting for 7 to 8 years. So we all know now it is HS. So how do you differentiate it from recurrent furunculosis?
Yeah, this is the early stage 1 HS. We can differentiate it from a typical location of the lesion, that is axilla, and also the chronicity of the lesion. It lasts for last 7 to 8 years, and there is a presence of recurrent painful discharging nodule. And in case of recurrent furunculosis, there will be inflammatory nodule with perifolliculitis also. Then there will be no chronicity of the lesion. There will be acute intermittent kind of lesion.
Yes, rightly said. The furunculosis will be transient. It would be pointed purulent, and it will rapidly respond to antibiotic. It won't last for such a long time, and it will have unpredictable distribution. If the immunity is okay with the patient, so it will resolve on its own.
And there will be no comedones in folliculitis,
yes,
furunculosis.
So how would you manage this case, Pallavi ma'am?
Because it is a single lesion, or maybe patient will ask for pain. It is, or she was treated earlier with any other, will choose antibiotic accordingly. Either will go for tetracycline group or rifampicin or benzoyl peroxide. And friction we should avoid, and I think we should avoid the deodorant spray regularly, and shaving also.
Weight reduction is also important. Along with that, patient has to quit smoking.
Yes, ma'am. Rightly said. If we take the medical component of it, so since it's a early stage 1, we'll start with topical or oral antibiotic, and if required, if it is having hard nodular consistency, we can give intralesional corticosteroid as well. And if it is very recurrent and annoying, then in rare cases we can go for punch debridement, and we'll let the scar heal with secondary intention. And when we come to lifestyle modification, we have to ask her to quit smoking and control her weight, and we'll we'll monitor the DLQI also. So case 2, Dr. Asmita ma'am, she is a 40-year-old female who presented with the complaint of recurrent discharging nodules for last 12 to 13 years. Presently, she is having discharging sinus over the groin area, and it was associated with excruciating pain, discomfort while sitting and walking. Past treatment history, she has been on variable doses of antibiotics including doxycycline for 12 weeks. So how will you manage the case?
The patient is clearly a case of hidradenitis suppurativa and has been taking antibiotics in cycles. At present, the patient is having pain and discharge. So there is inflammatory component. I will manage the inflammatory component with antibiotics. When the discharge settles down, I can introduce biologics also. Like, I am a very big fan of this intralesional steroids also. If there are isolated nodules, I initially with antibiotic, and if there is suppression of inflammation, I inject intralesional triamcinolone. And I can add, like you have not mentioned what is the weight of the patient, and where is, if the patient is having other metabolic disorders.
No, she is thin, ma'am. She is not having metabolic issues.
Fine.
Yes.
So I think we can start biologics or small molecules. Secukinumab is an option. Also, I have, though it is not FDA approved, I have started using upadacitinib for such cases, and I think it is working well.
So off-label studies are there, but ma'am, but then what to do with the fissure-like thing which has developed?
Yes, definitely. So the biologics will modify the disease, but it is not going to erase the structural deformity that has happened. So I will eventually try to take resort of deroofing surgery, and it can be regional excision or deroofing surgery.
Rightly said, ma'am. In this patient, what we did was we asked her to do absorbent foam dressing along with the modified antibiotic, because she has never been on tetracycline, so we have added rifampicin with clindamycin. And absorbent foam dressing is important because when we ask patient to do the dressing, or when we do it by ourselves in regular cases, we use adhesive dressings. Now these adhesive dressing, they causes micro trauma while pulling it out, or while having small motions also. So at this point, the type of dressing is also important. So we had used and asked the patient to do the dressing herself also, with the help of absorbent foams only. And if as you rightly said, if the patient doesn't respond, and if we think that only antibiotics doesn't give the desired response, then we have to add biologics, or off-label people are using JAK-STAT inhibitors, so we can try that. Third case, Dr. Archana ma'am, she is a 29-year-old pregnant female who is having flare-up in her first trimester. She is a known case of HS, and what would be the best management in her case?
Pregnancy added problems with the management of any disease, because it being an immunosuppressive and hormonally challenged state, so the disease gets flare-ups. So if she would have been not pregnant, then isotretinoin or acitretin is mentioned in the literature, but I find isotretinoin also gives decent results. And along with that, other modalities have already been discussed. If you have to go for a conservative way, clindamycin, topical clindamycin lotion, benzyl peroxide washes, and vinegar soaks will help along with the psychological support. And if at all it is pointing too much or discharge is there, a short course of antibiotic, which is according to the pregnancy trimester, could be given.
Yes, ma'am. And there are literature which says that if the patient is having recurrent flare-up and if the DLQI is more, then we can give adalimumab in second and third trimester as well. Next case, Dr. Richa ma'am. She is a 45-year-old female with BMI more than 36 with diffuse axillary discharging nodules with scarring for 16 years. She is having PCOS and metabolic syndrome, and she has failed all the treatment with the antibiotics previously. So what would be the plan of treatment in this patient?
First, we have to start with diet management along with lifestyle modifications. Then medical management will be biologics for this patient, as she has PCOS and metabolic syndrome also, and the duration is very chronic. So we'll have to start with biologics, adalimumab, and surgically we have to debride the lesions. And in some of the cases, CO2 lasers have been tried, but I don't know how the results. I have not tried it. But we have to work with combination therapy, medical as well as surgical, both the things.
Rightly said, ma'am. CO2 and NDAC both has been tried as a surgical modality, where the previous formed tracts and nodules have been debrided with the help of the laser, and it has been left to be healed with secondary intention. So yes, but they are not FDA approved still, but then people are trying. So in this case, as you rightly said, we have to deal with the endocrine and metabolic part with the help of either lifestyle modification, or we can add anti-androgens also, be it spironolactone. And we have to add some biologics. So we'll start with adalimumab since it's FDA approved, and if it is not working, we'll assess it at 12 weeks. We'll see the response criteria, and if it is not achieved, it is said that if you achieve it 50% at 12 weeks, then we say that the treatment is responsive. Otherwise, we'll shift to another biologic like secukinumab, and in last, if required, then we can go for advanced surgical procedures with the help of plastic surgeons like local flap surgeries. So as we have discussed, we'll add some combination therapy, the antibiotic, but she has already been on antibiotics for so long, so we have to have a bridge with that. So we will add some biologics, and as discussed, hormonal and metabolic modulators has also to be added. And again, biologics to be added and continued, and to be evaluated at 4 weeks interval. Another case, the last case, Pallavi ma'am, it's a patient with severe axillary and groin scarring with interconnected sinus tract and high volume drainage. And he is experiencing extreme chronic pain, social withdrawal, and is at a high risk of job loss. So he is a known case of HS. He is 45-year-old. So what would be the plan of treatment?
See, actually there is no specific diagnostic or tool for HS, but in this case we can go for ultrasound to see the track or deeper deep to the skin, how much it is, or multiple track is there. Then according to that we can go for medical and surgical or intralesional steroid and biologics also with the surgical deroofing and sinus tracking.
So with this case also, we have to start the advanced medical management. Along with that, we have to intervene surgically. First, as you rightly said, USG is used while doing some surgical intervention to delineate the localized tracts and the fibrous tract, so that everything is taken care of at the single stretch. And then the biologics is also added in this patient. And it can be added in perioperative period also, as it is not advised to stop the treatment completely. It is said that start with the biologic, plan for your surgery, do the surgery, continue the biologic, and continue the biologic even after the surgery. So the results and the response is more as compared to the any treatment alone. So earlier, I just wanted to highlight that earlier the notion of incision and drainage was there, but then we have seen that there is 100% recurrence rate with that. So what we have to do is that we have to initiate the systemic biologic or antibiotic, and we have to do the surgery in the form of deroofing and not incision and drainage, and in advanced form flap surgeries. And we have to continue that treatment even after the surgery. So perioperative period is also important in this patient. So Asvi, can you summarize according to the stage wise how will we proceed?
According to early stage 1, if there is single lesion, we go for topical treatment, and topical treatment like topical clindamycin or benzyl peroxide or antiseptic wash, or if there is painful lesion, acute painful lesion, then maybe go for intralesional triamcinolone, and then for early stage 2, we go for systemic like doxy and clindamycin, rifampicin, and for severe or diffuse, there is like we go for biologics along with surgical treatment.
Yes, you have rightly explained. Along with all that, we have to focus on the weight management, the lifestyle modification, which is very important. So to conclude, we have to do the systemic suppression, and to achieve definitive clearance there has to be perioperative period which should include any biologic, and before surgical intervention we should not stop any kind of biologic. We have to continue that and continue it even after the surgical treatment. So finally, it has to be the multidisciplinary pathway. We have to close the diagnostic gap by improving the diagnostic delay window. That is, we have to have a suspicion if a patient is having more than 2 occurrence of those nodules at particular area, which we have already discussed. We have to keep in mind the diagnosis of HS. The medical surgical bridge, we should not hesitate about using the surgical intervention in these kind of patient and using the biologics, because these patients are very refractory and have a very devastating course lifelong. And we have to treat beyond the skin. That is what we have discussed, the lifestyle modification and the pain management. And that's it. Thank you. Thank you all for the patience hearing.
Thank you, esteemed panelists, for such a rich and informative discussion. Now, I would like to request our panelist and moderator to take their mementos from near the stage. For next session, I would like to invite Dr. Mehtab Anam and Dr. K.K. Jha sir on the stage to chair the session. For the next session, I would like to invite Dr. Mehtab Anam and Dr. K.K. Jha sir on the stage to chair the session.
Dr. Pallavi is going to present updates on pathogenesis in AGA.
Thank you, sir. And a very good morning to all the esteemed faculty and the PGs. So my topic is little complicated, but I'll try to be more simplified as possible. So the evolving pathogenesis of androgenetic alopecia. So basically there are 2 approved drugs, 1 targeted axis and a hard efficacy ceiling. So 2 approved therapies are oral finasteride and topical minoxidil, both carrying persistent safety concerns. And the incidence rises with age, strong treatment seeking behavior in young men and women, and 1 targeted molecular axis. The therapeutic development remains constrained by limited pathophysiological understanding. So the question is, if androgen is the input, what is the actual effector lesion inside the follicle, and why does the blocking one node not restore the follicle? So what we are basically teaching, that there is genetic predisposition in the programmed scalp regions, testosterone then going for the DHT via 5-alpha reductase, and DHT binds nuclear and androgen receptor in dermal papillae, altered locally producing the paracrine growth factors and anagen shortening and premature catagen and prolonged telogen, the terminal to villus miniaturization. What is left unexplained? That is, androgen receptor polymorphism do not persuasively explain the phenotype. Neither serum nor the local cutaneous androgen levels explain the phenotype. It is unresolved whether transformation is mesenchyme driven, that is dermal papillae fibroblast immigration, or the epithelial, which is PGD2 dependent failure of the progenitor generation. The molecular basis of AGA in women remains still undetermined. So basically, the what is the miniaturization is understood as a failure across 5 follicular compartments, which is mechanical, regenerative, vascular, fibroimmune, and metabolic. So mechanical is connective tissue sheath hypercontraction activating the piezo-1 in progenitor outer sheath and outer root sheath and matrix cells, whereas regenerative is the apoptotic loss of CD3-4 progenitors and stem cell fade drift towards epidermal lineages. Vascular is androgen receptor driven regression of the dermal papillae and microvasculature. Fibroimmune, the Th17 and NK-CD8 plus infiltration, and the CXCL12 driven perifollicular fibrosis. Whereas metabolic is mitochondrial dysfunction, reactive oxygen species, and dermal papillae senescence. These 5 steps we'll be discussing in the coming slides. So according to a study made where the sampling, profiling, output and validation was done, so 76,386 cells were profiled, and after the quality check, 21 follicular cell types were derived, where the ex vivo human antigen follicle organ culture was humanized through SCID human scalp xenograft model. So in this, why this study plays a very important role, because when we consider the stages of androgenetic alopecia, we often only consider the miniaturization of follicle, but we don't consider that where this miniaturization is happening, which basic follicle cell is responsible for miniaturization. So this study basically helped to identify that what is basically happening inside the follicle, so that we can have other parameters also which are responsible for AGA. So the bulging follicles are mechanically squeezed and the sheath hypercontraction opens at piezo-1. The smooth muscle contraction programs upregulated in dermal sheath cells and vascular smooth cells of of balding anagen follicles. The PEZO1, which is the most abundantly expressed mechanosensitive channel in the bulge, and the outer root sheath and matrix cells is activated and intracellular calcium rises. The ectopic apoptosis of hair follicle progenitor cells and the proliferation of matrix and outer root sheath cells is suppressed, and henceforth the progenitor pool depleted and progressive follicular miniaturization happens. So hence we say that the bulge is intact, but the progenitor compartment is the one that is lost. So the upper bulge stem cell, which is CD200 plus upper bulge HFSC proportion unchanged in the balding scalp, and the reservoir of the stemness is preserved. The follicle is not exhausted. Whereas the lower bulge progenitor cells, which is cleaved caspase 3, loss of apoptotic and is graded, and it is graded, and the progenitor number and the proportion correlatively positively with the hair follicle diameter across terminal, intermediate and miniaturized follicles. And the stem cells that remains choose the wrong lineage. In balding follicles, more hair follicle stem cells differentiate towards interfollicular epidermis and sebaceous gland and fewer towards the hair lineage. So the DHT signals through basically two receptors, the nuclear antigen receptor and the non-canonical membrane, which is GPR133. So the nuclear antigen receptors acts in the dermal papillae and outer root sheath cells, drives the paracrine growth suppression and vascular regression, and target of the fenestride, dutastride and topical AR antagonist, whereas the non-canonical membranes, where the adhesion of GPCR is identified in the cell membrane as a membrane receptors of 5-alpha reductase DHT, and activation raises intracellular cyclic AMP expressed in human follicle connective tissue sheath, and DHT raised MLC2 phosphorylation and sheath contractility reserved by GPR133 knockdown. So what we interpret out of this, that AR targeting strategies alone may not be correct, the correct aberrant sheath mechanic. A structural non-pharmacokinetic limitation is always there. So the relaxing the sheath restored growth in the patient-derived follicles, target validation, not the therapy. The contraction abolished, the growth restored ex vivo, and the progenitors protected, and the additive in vivo. So what is basically in this, the male samples only, the no human safety or any efficacy data was taken. So authors themselves have noticed that there is a comparison with the fenestride cannot be made in these models, since fenestride acts in upstream, because all this is still under a lot of study, so we cannot just say that the fenestride only is not working. The perifollicular microinflammation now has cell type resolution and the severity gradient, the adaptive Th17, the cytotoxic NK and CD8+, and the proposed clue, which is IL-15. The T cells are the dominant lymphocyte population in the human follicular units, and the Th17 cells are significantly increased in the balding units, which is confirmed by CD4 and IL-17A co-immunostaining. And the IL-17 signaling is also upregulated in the vascular smooth muscle and endothelial cells of balding in the anagen follicles. When it comes to cytotoxics, NK and CD8+, the single nucleus RNA sequence of the Norwood Hamilton grade 5 follicles showed significant enrichment of the natural killer cells and CD8 T+ cells in the balding follicles. Whereas the proposed IL-15, the IL-15 critical for the NK and CD8 T+ cells proliferations was overexpressed in blood and endothelial cells and keratinocytes and fibroblasts of the balding follicles, proposed by the authors as the microenvironmental signaling driveway immune expansion. So follicular fibrosis finally has a molecular driver when it was seen in the mice. See, the androgen exposure, the dermal fibroblast, and the CXCL12, which is further signaling to CXCR4. And so basically in CXCR12 blockade attenuated and attenuated the stromal and immune changes, restored in the dermal papillae, regenerative capacity, and reduced the pro-fibrotic macrophage infiltration and promoted the hair regrowth. But there are certain limits to this evidence because it is entirely murine, no human and tissue validation has been seen. Androgen-induced model, not spontaneous androgenetic, and no clinical CXCR4 direct agent in the hair loss. So there are three independent data sets which converge on loss of pericular microvasculature. So one is basically the androgen receptor mediated paracrine signaling induced regression of blood vessels in the dermal papillae in AGA. The other one is dermal papillae cells in the balding follicles show marked suppression of angiogenesis pathway with collagen trimmer pathway upregulated. And the last one is all these factors which are downregulated in the balding follicles, and the blood endothelial cells lose angiogenetic program as well. So insufficient perifollicular vascularization impedes the telogen to androgen transition. So the aging arm, the aging also plays a very important role when it comes to the dermal papillae senescence. So DST exposure and mitochondrial dysfunction, which decreases the ATP and increases the reactive oxygen species, which leads to premature senescence and hence for the catagen entry and apoptosis. A reproducible microbial signal with casualty is still unproven. So most of the bacteria can also be responsible, which is QT bacterium acnes enrichment, the most consistent scalp microbiome alteration in AGA, particularly in male cohorts, and Staphylococcus corynebacterium malassezia, which is driven by the geography or methodological differences. So the proposed mechanism chain is the sebum triglyceride hydrolysis, which leads to free fatty acids, the TLR2 and NLRP3 activation of the follicular keratinocytes and sebocytes, IL-1 beta and IL-6, IL-8 and TNF alpha releases, and reactive oxygen species generation, apoptosis, and shortened anagen and progressive miniaturization. So this is basically a molecule elevated in the balding scalp is necessarily the molecule driving it, and hence the hypothesis is still listed and the receptor agonist strategy is still being studied. So from a single axis endocrine disease to multiple compartment niche failure, the model we inherited was genetic predisposition, 5-alpha reductase DHT, nuclear AR in the dermal papillae, altered paracrine factors, and shortened anagen and miniaturization. Whereas the model which is emerging now is androgen input via AR and GPR133, producing 5 effector lesions, which is mechanical sheath hypercontraction due to PEZO1, and regenerative, which is progenitor apoptosis, which is fate drift, vascular, which is dermal papillae vessel regression, fibroimmune, which is TH17 and NKCD8 and CXCL12 fibrosis, metabolic, which is mitochondrial, reactive oxygen species, and senescence. So as we discussed in all the slides, none of them have been proved that we can use them clinically. Very few have reached the stage of, as mitochondrial senescence can be said that it is an emerging, it is in an emerging stage. So still the minoxidil and finasteride play a very important role in the practice, but these things have to be considered. And we cannot deny the fact that not just the DHT but the other factors are also responsible for AGA. So these are the take-home points, that AGA is no longer a single-axis endocrine disease. The bulk survives, but the progenitus does not. DHT has an androgen receptor-independent arm. Nothing here changes today's prescription, but surely it will change later. And the genetic risk predisposition does not transfer to our patients. Thank you.
Thank you, Dr. Pallavi, for nice presentation. Any questions from audience? No questions. Thank you.
Thank you, sir.
Thank you, ma'am, for such an informative session. I would request the chairperson and the speaker to collect their memento from the stage. For the next session, I would like to invite Dr. P.V. Prabhakar sir and Dr. Vijay Kumar sir for the chair.
Good morning to all dermatologists present here. It is session on trichology. Now I call Dr. Rupa to come on the stage. Rupa's topic is newer molecule in trichology. I overtook Rupa.
Good morning, everyone. So today's topic of discussion is newer molecules in trichology. So why do we need newer molecules? We all know that minoxidil is effective for many, but adherence, hypertrichosis, and initial shedding remains the practical barriers. Finasteride, dutasteride, they target the androgen production rather than the receptor itself, but systemic exposure influences the treatment choice. In female androgenetic alopecia, there is a continued need for effective, well-tolerated options with appropriate reproductive counseling. In alopecia areata, JAK inhibitors have changed the treatment landscape, but response, relapse, and safety remain important. Newer generation molecules aim for local precision, deeper pathway control, and true follicle reactivation. The treatment paradigm is expanding. The currently treatment option, minoxidil, finasteride, dutasteride, anti-inflammatory and adjunctive approaches. The next in the development is local androgen receptor blockage molecule, which has a more selective immune targeting mechanism. In the emerging molecules, they target on androgen receptor degradation via the proteolysis targeting chimera, causing the follicle cell reactivation. Long-term research aims at regenerative signaling and precise follicular delivery. One follicle, multiple therapeutic levers. Androgens and immune signals, they cause follicular signaling leading to stem cell matrix response, leading to hair cycle output. We all know AGA has a miniaturization, shortened anagen, and androgen receptor driven signaling. In alopecia areata, the immune privilege collapse, cytotoxic T cell, and JAK-STAT signaling is involved. In regeneration, there is an emphasis on the dormant follicular stem cell activation and via the metabolic and niche signals. So in AGA, where are the newer molecules intervening? Unlike finasteride and dutasteride, which were reducing the DHT synthesis, the newer molecules clastrosterone, pyrilutamide, GT20029, they act on the androgen receptor. Clastrosterone, we have seen its use in acne. Clastrosterone in the percentage of 5% causes the androgen receptor blockage. It's a topical anti-androgen, and in phase 3, SCALP 1 and SCALP 2 studies, they enrolled 1465 men, and the subjects were instructed to apply 1.5 ml with a dropper to the balding areas of scalp, mainly vertex and temples, twice daily. 6 months results were statistically significant in both studies, and 12-month extension data as of April 2026 showed continued gains with ongoing treatment, and switching to a vehicle reduced the treatment gains. The next molecule is GT20029, which enters the follicular environment, and the androgen receptor is recruited to the degradation machinery. There is androgen receptor ubiquinization, and there is proteasomal degradation, leading to decreased androgen receptor signaling. It is in its phase 2 trial studies. In phase 2 studies, there were 180 men were recruited with androgenetic alopecia, and at 12 weeks, it was a randomized placebo-controlled study. 2 strengths were used, 0.5% and 1%, and it was compared with placebo. 0.5% was applied once daily, and 1% was applied twice daily. All active groups showed significant increase in the target hair area, non-vellus hair count as compared to placebo, and there was good tolerability. So it has a potentially deeper and longer lasting pathway control rather than simple receptor antagonism, but it is still investigational. So these are the molecules, and these are the target areas where they mainly act. We have already discussed about these. The next molecule is PP405. Can we reactivate the dormant follicles? The PP405 acts on the dominant follicular stem cell, and it causes stem cell and metabolic reactivation, leading to new anagen or hair regrowth. It is designed as a topical molecule. In its phase 2A clinical development, it has reported positive signals, and program is advancing towards the later stage studies. Unlike other anti-androgen strategies, the conceptual target is follicular regeneration and re-entry into active growth. The key unanswered question here remains the durability, breadth of response, ideal patient phenotype, and the long-term safety. So the PP405 molecule, the older question was, how do we stimulate a miniaturized follicle when minoxidil and anti-androgen approaches mainly on the environment around the existing follicle? But can a dormant follicular unit be pushed back into an active regenerative stress? So if this molecule passes through the trial, then it will potentially be useful across all the gender and phenotypes, but only if we confirm it in the later stage trials to be meaningful and have durable terminal hair gains. Alopecia areata. We have the target immunology has already arrived. In alopecia areata, the 3 main molecules which are US FDA approved are the JAK-STAT inhibitors, the baricitinib, which is a JAK1 and JAK2 inhibitor. It's approved for severe alopecia areata in adults at dose of 2 to 4 milligram daily in 2022. Ritlecitinib, a JAK3 inhibitor, its use is approved by US FDA for severe alopecia areata in adults and adolescents of more than 12 years at dose of 50 milligram daily in 2023. Duloxetine is a JAK inhibitor, and it is also US FDA for severe alopecia areata in adults at dose of 8 milligram twice daily in 2024. For alopecia areata, the clinical language is salt and not just hair regrowth. In the studies, they have seen about the change in the SALT score. The salt 100 means the complete scalp hair loss. So higher is the score, greater is the scalp hair loss. Salt 20 or less than salt less than equal to 20 means more than 80% scalp hair coverage has been done. And this is the common regulatory endpoint in severe alopecia areata trials. A statistically significant change can still leave a patient with substantial residual alopecia. So we have to consider this point also. So for any molecule to be effective, we have to see that how it is effective in how many patients, how fast it works, how durable it is, and at what safety cost. For JAK-STAT inhibitors, we have to screen the patients for tuberculosis and other infections. We have to get blood investigations done. We have to look upon the complete blood count, the lymphocytes, liver profile has to be done. Lipid profile can also be done wherever appropriate. We have to do a good counseling for the serious infections, like a serious infection, herpes zoster, for the risk of thrombosis and cardiovascular events. Malignancy warnings are also associated, and pregnancy considerations have to be taken care. We have to monitor with clinical symptoms, laboratory abnormalities, drug interaction, drug interruptions, and long-term risk has to be considered. We have to maintain a balance between benefit, risk, and burden. So what comes after JAK inhibition? We can get a more selective JAK inhibitor where the goal is to preserve the efficacy while narrowing the systemic immunologic effects. There can be TYK2 and cytokine axis. We can explore the downstream immune signaling with a greater pathway selectivity. IL-5, NKG2D, which target cytotoxic immunocyte biology implicated in the follicular immune attack and restoration of the immune privilege. Long-term goal is to stop the autoimmune cycle rather than to suppress it broadly. Regenerative biology, which includes WNT stem cell and the follicular niche. The stem cell niche causes the WNT and beta catenin signaling, leading to dermal papilla matrix stimulation and hair follicle into the entry into the anagen phase. The WNT beta catenin signaling is central to the follicular development and cycling. Pharmacological activation is attractive because it aims at follicular formation and regeneration rather than only growth stimulation. The challenge is specificity. Excessive or ectopic pathway activation can create safety concern. Future therapies may need follicle selective delivery rather than a systemic pathway manipulation. Drug delivery is becoming an important part of the pharmacology. So we have to design the formulation to concentrate the drug around the follicular unit. Development of liposomes and nanoparticles may alter penetration, retention, and release. And microneedling can potentially increase the delivery across the stratum corneum and into the follicular structures. The goal is to maximize the follicular exposure, minimize the systemic exposure, and simplify adherence. So in the future is a combination biology and not a single miracle molecule. So we have to stop the miniaturization, stimulate anagen, reactivate the dormant follicles, and maintain an optimized density. So we can have a combination molecule in which we can have a molecule which have anti-androgen effect like finasteride, dutasteride, or a local androgen receptor blocker, and which has growth signaling properties like minoxidil or future growth promoting agents, and regenerative properties like PP405 like follicular reactivation concepts. So how should dermatologists read a breakthrough hair loss headline? We should see the mechanism of the molecule. Is the biological target plausible or a follicular relevant? How was the trial design? Randomized, blind, vehicle, placebo control? What was the sample size? What was the end point? Absolute target area hair count, salt, hair diameter, photographic assessment. What was the effect size? The absolute difference from the vehicle placebo, not only relative improvement. Durability. What happens after 6 to 12 months or after the treatment stops? Safety, local tolerability, systemic exposure, class warnings, reproductive consideration, generalizability. Sex, can it be used in all genders, age, ethnicity, disease severity, duration, and phenotype. As of now, these are the available molecules, and some of them are still in its research. So what should we change in the clinic? A more topical precision. Patient who want to avoid the systemic anti-androgen exposure may have new option. Mechanism, match treatment, AR-driven androgenetic alopecia, immunity-mediated alopecia areata will increasingly be treated as a biological distinct disorders. Long-term adherence with the treatment option. And the regenerative therapy should expand to addressable patient pool. So we can expect combination therapy to be available in the future. So the future is less about a stronger minoxidil and more about precision control of the follicular biology. Thank you.
Nice presentation, Rupa. Thank you for it. I think there is no question from audience. Any question? No. Thank you. Okay.
Thank you, sir.
Thank you, ma'am, for such an informative session. I would request the chair and the speaker to collect their memento from near the stage.
Next, we have a panel discussion for which I would like to invite Dr. Priyanka Parmar on the stage.
Good morning, everyone. So I'm Dr. Priyanka Parmar, and I will be starting the discussion over the procedures management of androgenetic alopecia. I would like to invite all the panelists, Dr. Abhishek Ranjan sir, Dr. Akansha Singh, Dr. Rajiv Thakur, Dr. R.R. Madhukar, and Dr. Vanshika Rai. Please come on the stage. Shall I start? So basically we will follow the procedural landscape in AGA. First we'll discuss autologous biologics, then physical and photonic, and then advanced as surgical. So sir, would you like to say something about what you do in your daily procedures for AGA patients?
Basically, in general clinic in our dermatology department, we usually do basic analogous biologics, mainly PRP, GFC, and microneedling. These are the common procedures that usually we go through. And physical, photonic, and advanced surgical. Some good clinics have their for physical and photonic, but surgical is not common in our dermatology practice. Yes, so basically we do PRP, GFC, and microneedling.
Sir, if like 25-year-old male comes to you with hair thinning, and he is asking for, like he has applied minoxidil for 6 months and he is not benefited by that. So what would you suggest for that patient?
See, you're asking about a 25-year-old patient, right? So 25-year-old patient, first you need to counsel him and stabilize the hair loss. Because any treatment if you give to a 25-year-old, you have to go for a longer period, right? So basically, when we start to treat any AGA or any hair loss, the first and most important part is counseling. How do you counsel the patient?
Yes, sir.
Like, what is his expectations? If his expectation is like, I want full, my scalp full with hair density, we can't do that in a day. So first we have to counsel him and start with stabilizing his hair loss. First we have to stabilize his hair loss. It should not go further in alopecia. So first we'll counsel and we'll start with medical treatment, stabilize it, then we'll go for other procedure.
Yes, sir.
Once it's stabilized.
Yes, sir. Rightly said by sir, because counseling is very important for a AGA patient. As we know that it's very difficult to manage AGA patients in the one who is suffering in very young age. So when should procedures be considered instead of medical therapy alone, sir?
See, if a young patient, AGA patient is coming to you, so it's your responsibility also to either protect his hair, and if you think that no, there is a need of transplantation, then you should refer early, because early patients, if it is he or she is going for transplantation, so he will need less number of follicles, less in low cost they can achieve the their target. But if you are seeing that no, it's not not for good for this transplantation, but you can do this procedural things also.
Yes, sir.
So you treat aggressively. You don't have to wait for 3 months that okay, I'm giving topical minoxidil or oral minoxidil, then we'll start PRP, then we'll start. You have to counsel him if the patient is ready, and you can start aggressively with medical treatment along with this procedural labs, and not, if not, then better to have early transplantation.
So could you please explain the mechanism of action of PRP in AGA? Like what actually it does?
PRP?
Yes, sir.
See, PRP has some role according to the studies, that it helps in hair growth, okay, and sustainability also.
Yes, sir.
So we can start early if the patient is ready.
Sir, does platelet concentration affect clinical efficacy?
See, PRP, what it does, it increases the circulation, and it activates VG, endoendothelial growth factors, and PDGF, and these growth factors which stimulates further for hair production. Like it is good for miniaturized hair, not for full anagen growth. And basically it also depends upon the concentration, as you asked. So basically from baseline 3 to 6 times you should have a good concentration. More than 3 times is enough, but as you further go, up to 6 times is a good result. If you get from like 4.5 lakh or something, you'll get a good concentration and you'll get have a better effect on both the growth factors. So for that.
So do you think exosomes would be better or GFC would be better in patients whose hemoglobin is less than 10 and the platelet concentration would not, like up to the level of...
I think this exosomes is very less evidence is there for exosomes. It's still in the experimenting phase, right? So the first GFC, GFC is better than PRP according to my, I cannot say I have substantial evidence, but I have seen in patients, and there is some intellectual fact. If you think like it already has growth factor in their serum, right? When we centrifuge GFC with PRP, like PRP has no growth factor in it. It goes inside and then activate the growth factors. But in GFC, we already have growth factor in the tube. So when we infuse it or we inject it, it will have a better effect when hemoglobin and platelet concentration is low.
Yes, sir. Ma'am, would you please tell us the injection technique and depth are used for scalp PRP?
In PRP, we use the injection should be given at an interval of 1 centimeter, 0.1 ml of that liquid or PRP should be injected at one place at an interval of 1 centimeter, and it should be injected at the depth of around 1 mm, 2 mm, or up to maximum up to 3 mm in depth. But
Yes,
more
ma'am.
depth will cause the chronic inflammation, and it can cause hair follicle fibrosis also.
Yes, ma'am, rightly said. So how many sessions are usually required and at what interval? So do you, ma'am, follow the induction phase and maintenance phase, or you just...
In my practice, I usually suggest my patients to go for 4 to 6 sessions of monthly PRP. If he can afford, I'd ask him to go for twice a month therapy as well for the first 2 months, and then he can switch to 3 monthly or 6 monthly maintenance sessions.
And what are the common adverse effects of PRP that usually you notice in the OPD? The patient comes in.
As for my experience, usually I don't see much side
Yes,
effect
sir.
actually, apart from pain and headache in some patients. But yeah, I need more experience to say anything about it.
Exactly, there is no any such side effects. Simple headache and
Yes.
pain patients may complain, otherwise nothing. And for the previous question, you were asking depth and this.
Technique.
So for any beginners, insulin syringe is the perfect for giving this PRP, because the needle size is also according to the
Yes, sir.
protocol, and it is also 30 or 31 gauge, the needle shape. So it is best for any beginner or anyone who wants to do PRP.
Yes, I'd also like to answer that question. There is another technique called as the nappage technique, where a very small amount of
Yes,
the
ma'am.
PRP is injected very close. But usually we don't consider that because of the pain factor. We usually consider like making less injections.
How would you manage, ma'am, the patient who is having more pain?
First of all, I just go for topical anesthesia, number one, which
Yes.
mostly does not work very effectively, I've seen practically.
Yes,
Then
ma'am.
we can go for ice rollers. I usually, in a low setting, I just put one ice cube in a glove, and you can just locally use it. And then vibrating devices are there. So all that.
Yes, ma'am. Now many dermats are preferring using vibrating machines.
Mostly I use that ice roller, and that's enough.
Yes, ma'am.
Spray also works good. The spray which comes there, lignocaine spray.
Lignocaine spray.
You just spray, wait for just 1 or 2 minutes, and then you can do better. than
Ideally,
what-
1 or 2 minutes is enough, sir.
But if the patient is having very low density, then only it like penetration I see is good. If patient is already having much dense hair, it doesn't get penetrated. Like,
Yes, yes, ma'am. So, what is the rationale behind microneedling in AGA? So, do you think that it is effective doing microneedling for patients in AGA?
I believe microneedling is an adjuvant. Like you have to adjunct, like you have to combine it with something.
Yes, sir.
Only microneedling doesn't work so much. For microneedling, if you're doing, if patient is on minoxidil, right, minoxidil and finasteride combination. So microneedling is a good combination therapy with PRP. If you're doing PRP, microneedling and medical has a good result. So what it does, that microneedling, when you do microneedling, you ask patient to stop for 24 hours to stop applying minoxidil topical, because it can get rapidly absorbed and cause side effects. So and because it gives a better penetration to medicine, and it also helps to distribute the platelet all around the scalp.
Yes.
So it should be combined with either medical treatment or PRP.
So do you think that microneedling increases the efficacy of topical minoxidil?
Yeah, definitely. Definitely it increases the efficacy of the medical, because what you're doing is you're enhancing the penetration of the medicine, right? So whenever there is a space where medicine get absorbed easily, you'll have a better drug penetration, you'll have better drug delivery, and it will affect better.
Better, okay. Is microneedling...
Nowadays your patient comes and asks you that, doctor, can I use derma roller?
At home.
What, at home? How,
Yes.
what the size should I use? How should I use? So it's your patient that they are demanding. So you have to give this microneedling concept. Most of the patients I give derma roller. I used to keep 1.5 mm derma roller and give to the patient. Those who are demanding and those who are asking. Have weekly therapy, 6 days minoxidil, 1 day derma roller, again 6 days.
So they do at home?
They do at home. You just have to see horizontal, vertical, 4 rounds you have to take, and they do. Most of the patients do who ask.
In my opinion, microneedling is micro trauma. And once you induce trauma, you release endogenous growth hormones itself.
Yes, sir.
So that's the basic funda of microneedling. Whether you're doing PRP, you're doing exomes, you're doing delivering any
GFC.
medication, it's the micro trauma which is actually working. It's increasing the blood flow. And because of the blood flow, there'll be better absorption. That's my opinion. So I just use anything they are comfortable with. I don't do PRP.
I totally agree with you, sir. So, do you also think that microneedling is effective as monotherapy?
Like not as monotherapy, we must give the patient oral medication along with the topical medications, and as an adjuvant therapy we can add microneedling without PRP as well.
Nothing works as monotherapy. You say melasma, you say vitiligo, psoriasis, or your hair patient. Nothing works monotherapy. You have to combine.
Yes, sir.
Because of the cost thing also, like if patient wants, we can provide derma rollers to him, like for home use, and if he agrees for PRP, we can do PRP with microneedling, but if patient cannot afford, we can give just monotherapy like as a procedural treatment.
Next, we'll go to low level laser therapy, that is light therapy also. So what is the mechanism of action of triple LT in AGA?
Basically, for LLT, the mechanism is if you're delivering at 650 to 690 unit wavelength, then it triggers nitric oxide, which causes further vasodilation. So in hair, if you're going any treatment, you need to deliver blood to the hair, right? So basic fundamental is this. So you have to deliver the hair, the constituent of the blood that stimulate the growth factors or increases the stem cell or cell differentiation. So basically, same thing hair light does. The light causes nitric oxide stimulation, which further causes vasodilation.
Yes. So which patients are most likely to get benefit from?
Same as which I told you, Norwood classification, AGA, I think 2 up to 3, not more than that,
Yes,
2 or 3. And basically, in people who have visible hair follicles but miniaturized, not bald spaces. You cannot do LLT on balds where is a full bald patch where the hair is not visible. You should have some follicle there to stimulate its growth.
So would you consider hair transplant for that patient then? If more than like he's having frontotemporal plus central loss.
See what I told you, Norwood classification, after 3 we can recommend hair transplantation. I think before 3 I would suggest go for stabilization and medical treatment along with the procedures. But depend upon the first, you have to counsel the patient like expectations. What's his expectation with the transplantation, and how is donor area, and what's the bald spaces are there. So for bald spaces, I will suggest hair transplantation if the patient has stabilized hair loss.
So for example, a patient of 30-year-old comes to you and he is getting married in just 6 or 8 months. Then what would you prefer? Like, would you go for hair transplant? Because in those cases, as you know, we can't go for PRP or exosomes.
See if he's getting married in 6 months. We won't
because
do.
he wants to look, cosmetically he wants to look better than
Yeah, because it will take another 1 year, 2 year to get his hair normalized after transplantation. So yeah, if he depend upon his expectation and counseling. So if he requires immediate result and he had that spacious bald spaces where he stabilized hair loss and we can has a good donor area, and if we can do, we can do. It's okay, it's fine. But 30-year-old, we could wait for some time.
Yes, sir. Because in my practice, like when I was doing residency, I have seen that kind of patients also. They come eagerly, they just say, I would go for hair transplant, do something for me.
Patients will ask. Patients will ask. Patients wants magic. We can't do magic, right? We can give whatever in our power we can do is counsel them properly. For hair, you need a good counseling. If you do it properly, the patient will understand eventually, because he has gone to so many places, tried Adivasi Tel and everything. So basically, he'll understand if you do a good counseling. And for better, I say up to 30 years or 35 years, young age, we should not ask for.
Yes. According to you,
disease should be stable. Disease should be stable, or else transplanted hair area will have more growth. And because of the ongoing disease process, we can see a separate demarcation line between the transplanted hair and the ongoing hair, ongoing hair lost areas, on the vertex side. If you have transplanted up to this level and disease is not stable, so because of the ongoing hair loss, there will be a bald area in this area. So disease should be stable. It must be stabilized first.
Yes, ma'am. So what is the difference between FU and FUT? Like follicular unit extraction and...
See, I have not done hair transplant, but I have theoretical knowledge about it. Basically, FU is follicular unit extraction, and T is transplant. We do in T, we take a hair band.
Yes, sir.
Theoretically, I'm speaking. So we take a hair band and then we do follicular separation, and then we inject in the recipient area. So basically, FU has a side effect, it has a hair get damaged. It is a costly and time taking, but is a better for patient's point of view. But if patient is not afraid of scarring or is not worried of these stitches, we can do FUT. Still, FUT is better in theory, I'm saying.
Yes, sir. Now many dermats are preferring.
Nowadays, FUE is
more
only
preferable.
going in trend. FUT is now old and not being used. Even plastic surgeons, they are doing FUE. A new derma who's starting hair transplant, they are doing FUE.
Sir, what factors determine the graft survival? What you consider in for the graft survival?
Madhukar boss, you do hair transplant.
I refer them to my senior colleagues, more experienced colleagues.
So, what was your question again? Sorry.
What factors determine the graft survival?
See, number of follicles, of course. Number of follicles, because more than 20-30% follicle will shed off after transplantation. So, all are theoretical fact I'm speaking. So, basically, good hair follicle, donor area, good hair follicles, Second, the transplantation technique. And third is after procedure, what you're doing, like for PRP, medical minoxidil, you have to continue care for your the recipient area for a longer period of time.
Right.
Yes,
After
sir.
transplantation, care is very important. Like you cannot just get it transplanted and leave. And other systemic many factors might be there, like having any systemic symptoms like diabetes or something. It also matters.
Patient compliance is also important. So we will go on exosomes and PRP, and what is the comparison between PRP, exosomes and GFC? So what do you think? Which one would be better for a patient who is feasible, like he is ready to pay? So if he is
Definitely
payable,
GFC in a patient who is ready to pay, although PRP also works nicely. But then in GFC you are already breaking down the growth factors, you are packing it up in a serum and injecting it. It would be less painful. You can assure a better result to the patient. So definitely GFC. I think GFC better than exosomes or PRP. Although PRP also works very nicely in practice.
like have you seen, ma'am, like it's a good
Yes, of course. In PRP also I have seen good results, but in GFC I have seen that patients come with a better density. I don't know, it might be just psychological that I'm paying more so I'm getting better results. It might be like that. But then I have seen people get good results with GFC. Have seen that.
like many female patients, they suffer from anemia. So in those cases, do you feel that GFC would be better option for them?
See, initially I advise PRP only if it does not work, because I don't screen every patient for anemia. I'm not seeing the platelet count in every patient before doing the procedure. So can't say that. Initially I just give them PRP. If they're happy with the results, it is okay. If she's not happy, then we can go for the other things.
Like should we consider doing normal CBC before?
CBC is, I think, is a compulsory cheese. If you are going for any procedural PRP or GFC, just do a simple CBC.
Yeah, if you are planning for a procedural treatment, then we should go for routine screening test along with, we do viral markers. So in that time only we can advise CBC as well. And if patient is anemic, we should treat the anemia first and give the other oral medications and other supplements first. And then we can go for PRP. And before that we can plan GFC first.
It's my question instead of an answer.
Yes, sir.
That we are re-injecting platelets, right?
Yes, sir.
So why the need for hemoglobin?
Sir,
if you want to check, you check for the platelet count.
Yes, sir.
Platelet count should be convenient enough. It should be ideally it should be above 2.5 lakhs.
Yes, sir.
For the proper PRP precipitate.
2.5 to 4. So, is PRP plus microneedling superior to either treatment alone?
What's your question? Excuse me, sorry.
Is PRP plus microneedling superior to either treatment alone? Should we consider?
Yeah, definitely there will be some better result in combination therapy in hair. In hair, nothing sir said, nothing works as a monotherapy in dermatology. So, yeah, it's true. You need some extra things, like if you're doing, if you're asking on evidence base, yes, there is a difference. PRP and microneedling has better result in theory also, in some articles also, than alone. But I am saying that microneedling is always adjuvant, always combined with some procedures. So alone PRP also has good result, but if you're doing with microneedling, it will have some better result.
Sir, like a patient has undergone 3 PRP sessions but reports no improvement. What factors would you evaluate before continuing treatment?
Platelets, as I said, platelets is must. You should get report for platelets, how's the platelet count and concentration. It's better if you do centrifugation and then count the platelets. So
Okay.
it will tell you
Patient
platelets.
was on monotherapy or like he was on PRP only?
Only PRP.
And
Just
In that case,
monotherapy.
we should
I think
evaluate like we should go for screening test as well, like CBC and his other nutritional deficiency screening as well. And along with that, we should start some systemic oral medication along with PRP. And obviously, we should go for platelet count as well.
We
Or
we
topical
give,
minoxidil.
We can even give dutasteride exomes which are coming.
Yeah, finasteride and dutasteride.
Dutasteride is come, so you can give that. It will be also equally good as delivering this thing. Giving them systemic dutasteride or finasteride, you are delivering it directly at the target site.
Yes, many male patients, they don't easily agree for taking finasteride.
Means
So
many people Google up and come to you that
Yes,
has side
so
effects. So
it hardly
you have
is.
to explain to them what's the dose you are giving. Firstly, secondly, here you are injecting directly to the target area, and you're getting a better result because you're doing microneedling along with dutasteride.
Yes, sir.
So that and how much will be absorbed in the skin from there. So you can easily, safely, and
Consider.
even counsel the patient that you are not you're taking dutasteride or finasteride for the side effect.
Yeah, and also in AGA, like only PRP is not going to work, I feel.
Yes, ma'am.
We should do we should give some other medication, either it is topical or oral, and we can counsel the patient that without other systemic treatments it's not going to work with only PRP.
And ma'am, when should you stop procedural treatment and consider hair transplant in patients?
Yeah, obviously after grade 3, we should consider stabilizing the disease process first, and then we can go for hair transplantation. And if patient already has tried everything like oral minoxidil and oral finasteride and oral supplements, along with the topical finasteride and minoxidil and PRP, GFC, everything, and with derma roller or without derma roller, then obviously we will have to consider the hair transplantation like FUE or something.
Yes, ma'am. As my questions has ended now, still 1.5 minutes is left. So, would you like to?
You can share your experience about exosomes or PRP or GFC, what you have done.
During my residencies, sir, the patients that I have seen, I have injected exosomes a lot, and I have seen better results in patients who has gone through exosomes over PRP. It's just that patient, you have to counsel them very, in a way that they should be compliant enough. Because in some patients, they unexpectedly, they expect, miracles. So after 1-2 sessions, I have seen they become impatient and they will be like, मैम कुछ हो नहीं रहा है, कुछ असर नहीं हुआ, पैसे भी खर्च हो गए. So that is the most common thing we in general see in the OPD. The patient are very impatient.
That's why I charge for minimum 5 sessions. You have to, you say, you give for 5 sessions and then you will see the results. Then patient will come.
Counseling is tough, sir.
No, the counseling, in the counseling part, you have to counsel that even when you achieve the results, you need to continue with the medication, otherwise
Yes,
you'll be back to square one. That is the major part of counseling.
Yes,
Because they
sir.
think that once I have seen many patients, 6 महीने में बहुत अच्छा बाल आ गया, सर उसके बाद हमने दवाई छोड़ दिया, आपने तो बताया नहीं, अगर बताया होगा, हाँ बताया था लेकिन भूल गया.
Yes, sir.
Or you can self-advertise like me, like if you want a good hair like me, you have to be patient and be
Right,
patient and listen to me.
Yes, sir. Yes, sir.
That the first step should be the counseling part, that we must tell our patients that even after gaining your desirable result, you need to continue some other type of treatment. At least one serum should be
Exactly.
continued lifelong, or as long as you want your hairs to be there on your scalp.
Yes, ma'am. Thank you so much, sir. Thank you so much, ma'am. Thank you, everyone, for listening it.
Thank you, esteemed panelists, for such a rich discussion. We were very delighted to hear you. For next session, I would like to invite Dr. Mohammad Mukhtar sir and Dr. Pankaj Kumar Agarwal sir on the stage to chair the session. Also, I would request the moderator and the panelists to take their memento from near the stage.
Hello. Now I request Dr. Archana Lokhande to please come on the stage. Dr. Archana Lokhande. Today's topic of our is acquired dermal macular hypermelanosis. What's new? Archana Lokhande, please kindly start.
Thank you very much, sir. Myself, Dr. Archana Lokhande. Today I will try to simplify this difficult terminology. Acquired dermal macular hyperpigmentation. So, what we are going to learn or understand in this presentation, as there is a lot of confusion, and we'll try to gain some clarity in this pigmentary dermatosis. So there are multiple names: acquired dermal macular hyperpigmentation or pigmentation of unknown origin, but it is a spectrum disorder. From nomenclature to management, the disease has multiple patterns. We'll try to gain some clinical and pathogenetic insight in this disease. So it is not just melasma. It is a common chronic and cosmetically distressing condition for the patient. And often it is mislabeled as PIH. So there should be some uniform concept to confirm or get a better diagnosis and management of this disease. So what to do? Let's know it so that we can spot it and we can treat it better. So we'll be defining what is ADMH, its spectrum, its subtypes, its etiopathogenesis, and a practical treatment algorithm through this presentation. So earlier it was called macular hyperpigmentation of uncertain etiology. It has overlapping entities, and now we'll try to fragment the spectrum. So basic problem, the pigment which is there, which should have been there in the epidermis, has dropped down to the dermis, and along with that pigment, it has caused a subtle inflammation, so which is leading to acquired gray-brown to slate-colored macules or patches. The problem with the Indian skin, which is either skin type 3, 4, 5, that slate pigment is very prominent, and we are obsessed with getting fairer. So that is generally unacceptable for the patient, and it is psychologically a burden for them. So there is interface dermatitis with dermal pigment incontinence and dermal melanophages. Minimal or no previous preceding inflammation, erythema or scaling. So this is the histopathological finding, and this common histopathology is shared in almost all diseases in this spectrum. So they have a shared clinical morphology, overlying histopathology, and some common triggers are there. So 4 major entities we have: lichen planus pigmentosus, which is our favorite, followed by erythema dischromicans persistens or ashy dermatosis, then followed by Riles melanosis or pigmented contact dermatitis, and idiopathic macular eruptive macular pigmentation. So all of them differ in their distribution, tempo and trigger, but they share the same basic pigmentary outcome and histological pattern. So what is there? There are gray-brown macules with little scaling, okay? Often asymptomatic, initially mild B, little pruritus could be there. The favorite sites of the disease are face, neck, trunk, flexors and photoexposed area. So that's the basic cause of distress, that the disease is present on the photoexposed area and the cosmetically sensitive areas. So every disease follows a distribution, and that distribution tells us the story. So we have to recognize the pattern. Face and neck is generally favored for LPP and Riles melanosis, trunk and proximal limbs for ashy dermatosis, and exposed site for pigmented contact dermatitis. Like in LPP, the presentation is more peripheral in the face, and in the pigmented contact dermatitis, it is more in the central of the face. There is a reticulate pattern, there is a chronicity, and there is a dermal pigment. Now slow, subtle, stubborn pigmentation, that is a simple simple description of planus pigmentosus. There is an insidious slate gray to brown pigmentation, which is common in the skin of color like ours. Face, neck, flexors, and photo-exposed area. Neck is very important area. Patient is often concerned about the face, but you will always find the lesions on the neck, and especially on the sides of the neck and the front part of the neck, not on the back of the neck. And at times when it is there on the back of the neck, you will get on the upper back and the front of the back also, front of the chest also. So it has got predilection for the sun-exposed area, and it supports the notion that ultraviolet radiation play a very vital role in the pathogenesis, but still there is no known photosensitizing agent which we are able to find out. So LPP is one of the most common ADHA, often with a slowly progressive disease and with minimal visible inflammation. So these are some of the photos of my patients. So the areas around the mouth, areas around the eyes, areas around the temple, lateral area, and you can see the lacy reticular pattern. You can identify, you can see the slate gray pattern. At times it causes a lot of erythema also whenever you are giving multiple therapies on the face. Now these are the classic findings you can see on histopathology, on dermoscopy. Now coming to the ashy trunk, that is erythema dyschromicum persistens. So ashy gray macules and patches mostly on the trunk and proximal limbs. Early lesion may have faint erythematous border, very difficult to differentiate in the skin of color. So early lesions may show subtle erythematous rim, but we cannot, it is often missed. Now there is a diagnostic criteria. The lesions are asymptomatic, non-elevated, they have light erythematous border, exposed or unexposed, both the parts are involved, no mucosal involvement, and rarely improve. That is the key feature of all the diseases, they rarely improve. Now coming to the Riles melanosis. So Indians love cosmetics. Why they love? They are obsessed with the color. They want to get fairer. So facial pigmentary disorder, it is linked to cosmetics, fragrance, hair dyes, and strongly associated with repeated exposure. So careful history of cosmetics, hair products use, and patch testing is often relevant. I would like to share one of my personal opinion in this regard. We have to switch to minimalism in using any kind of products, whether it is sunscreens, moisturizers, or dyes, or oils, because a lot of things are adulterated. We don't know the actual composition. They are having endocrine disruptors, so carcinogens, fragrances, so less is more. And when people start applying one or another layering with 10-15 types of skin routines and adding perfumes and deos and all, that is a basic problem which is causing all this kind of. Secondly, hair dye, which is underrated. We have to accept that we are aging. Why we are not accepting that? And we are applying harsh hair color again and again. And we don't know when is the culprit and when the trigger is switched and when the pigmentation starts. And even when starts, people are not ready to accept to stop the hair dye. That's just my opinion. So these are few of the cases, but these are not classical pigmentary contact dermatosis. Now coming to it is a low-grade contact hypersensitivity, minimal eczema clinically. Pigmentation is the dominant feature. Essentially, it is a contact dermatitis where pigmentary changes overshadows the eczema. So we can find out with the contact patch testing, which is the ideal method. Now there are many triggers, but outcome is same. So it is a multifactorial, either contact, either UV rays, either friction, or genetic switch, either cosmetics, hair dyes, fragrances, topicals. So it is very difficult to identify a single trigger, and all this lead to in a patient with genetic predisposition, it may contribute or trigger the inflammation and leading to the dermal pigmentation. So coming to the last entity in the group, idiopathic eruptive macular hyperpigmentation. So it is a benign eruptive brown macules. Children and younger adults are more commonly involved. There is no prior inflammation, and it commonly seen in both the dark and lighter skin types. It is an epidermal hypermelanotic condition, and lesion appears suddenly and it is resolved spontaneously. So among all this is a better one, we can say, in terms of prognosis. So what is the problem? The dermoepidermal junction is getting hit, interstitial dermatitis reaction is there, and the melanocytes are dropping to the dermis. So there is subtle basal keratinocyte injury, interface dermatitis is there, pigment incontinence is there, dermal melalophages which are going to stay there forever, and they may take months to years to clear. And all this produce a persistent hyperpigmentation which is giving slate grey appearance because of the Tyndall effect. Now it is a T cell driven pigment. So immune mechanisms like cell mediated immunity, delayed hypersensitivity, chronic low grade inflammation, all these are playing role in this. Now it is very important to find out culprit, what is causing the problem. The sun, the role of the sun exposure cannot be taken lightly. Strict photo protection is the fundamental part of management. Now the interface histopathology we have discussed earlier only. These are the dermoscopic findings which are very characteristic lacy grey pattern you get, and deeper the pigment, darker the pattern. And might you see sometimes erythema because of the application of the cream or telangiectasias associated with it. So on dermoscopy we get grey brown dots, globules, hazy blue grey areas, reticular pigmentation. So dermoscopy definitely helps in dermal pigment deposition. One thing I would say to all, even if you are not very good in dermoscopy, put the dermoscope in any patient of facial pigmentation. It will give you the idea at least where the pigment lies, and it will help in making patient understand with the picture, see your pigment is here, and every visit we can check the prognosis also with that. So this is just an algorithm which will help to find out where the pigmentation is staying and what all the types of pigmentation. Now what is the how to reach the diagnosis? The history, clinical finding, biopsy or dermoscopy, all in total will help to reach a diagnosis. So what are the differential diagnoses? It is not at all a melasma, or it is not at all a post-inflammatory hyperpigmentation. So there are multiple things which need to be ruled out. So this is just the differentiating points between LPP, ashy dermatosis and real melanosis. And these are the differential diagnoses for acquired hyperpigmentation. We are going to skip these slides. So what is the strategy? We have to be smarter in doing biopsy. Whenever required, go for the patch testing, and limited systemic workup is generally needed unless indicated. Now what are the treatment goals? We have to control first and lighter later. So to stop the active disease, we have immunosuppressant, tofacitinib, mycophenolate mofetil, dapsone, clofazimine, hydroxychloroquine or methotrexate. So if there is active phase of interface dermatitis, we have to find out what is the best which will work for the patient. So residual pigmentation will take time to get clear. Avoid suspected cosmetic hair dyes, barrier repair, gentle skin care and photo protection. Now topical therapy, calcineurin inhibitors, they are very much important, tacrolimus. We should avoid irritation. In systemic therapy, I have already explained. Now procedures, they are the last set of resort. So when the inflammation is settled down, we will go for the procedure. Laser works best, followed by chemical peel. If we are doing laser, the interval between the laser is very important. It is not frequent. It should be 2 months to 3 months, because we have to give the time for dermal melanophages to clear on their own. So this is a very good article, Updates in Therapeutic Management of Lichen Planus. So coming to the last, this is one of my patients who has got worsened with the treatment. That's what I felt. And The take-home message is, it is chronic, slow to improve disease. So stabilization is the success for repigmentation, and repigmentation is gradual, often incomplete. So strict avoidance of irritants and photoprotection lifelong is important. So the gray color matters to the patient, so we have to take it very seriously as it is affecting the psychology of the patient. Thank you very much for your patient listening, and thank you very much for the AI tools which have helped me to make this presentation. Thank you. I hope everyone has enjoyed it.
Thank you, Archana, for finishing your presentation in a very nice time. And it was a very, very provocative and very important presentation. Nowadays, we see a lot of cases in our clinical practice. So it was a very nice to say on this topic.
Thank you very much, sir.
Any question from the
Have you come across about the hyperpigmentation due to mustard oil? Is
Sir,
it common?
not so frequently, because might be I have not taken that history deeply, but I feel hair dye is the most common cause in my practice.
Mustard oil.
No, sir, I have not seen
It is very common. I diffuse hyperpigmentation of face and even neck.
Sir, generally I have the patients who are applying skincare routine, so mustard oil doesn't come in their skincare routine.
In male.
Thank you very much, sir.
Any question from the audience? So we move to the next session. Thank you.
Thank you so much, ma'am and sir, for your wonderful session. Now, I would like kindly request our chairperson and speakers to kindly collect their mementos. For next session, I would kindly request Dr. Birender Prasad sir and Dr. Rajesh Kumar sir to chair the next session.
Good morning, all of you. Sorry. Good morning, all of you. New speaker is Mr. Iran Mathwe, and topic is genetic and mosaic hypopigmentation in infant and children. So please come.
Good morning, everyone. We have a few minutes till afternoon. So hopefully this will be brief and sweet. So I am dealing with the genetic cause of hypopigmentation in children. And my first slide is why is this relevant. So whether it is routine practice or in academia, we know that genetic disorders are a very small part. And definitely in Clinicon, all of you will be wondering why not go for lunch or sleep through this. So acquired hyperpigmentation when we have in infants and children, it's primarily dermatological issues, and this is our bread and butter as dermatologists. Parents are worried, is it vitiligo? We are worried, is it Hansen? And plenty of people have post-inflammatory pigmentation and other dermatosis. So I'm assuming all of us are quite familiar with these conditions, the counseling and the difficulties in management. So genetic cause of hypopigmentation, why do we need to allot some time to it? So this is primarily because there are systemic concerns, not in all, but in some which we should not miss. So the systemic concerns are affecting three major systems. One is the CNS, eye and ear. Because of the common development, we consider those together. Then the involvement of the immune system, which is rarer but definitely more dangerous, and involvement of the platelets. So we'll see why this happens. So why these systems and cells? So before going into how we can actually implement these in clinics, I'll be boring you with 3 majors from the textbooks. So one is the melanocyte migration. So rather than remember this, we just need to remember where the melanocytes have migrated. They have started off from the neural crust and they have migrated to skin, which is concerned to us. They have migrated to the hair. They have migrated to the inner ear, they have migrated to the brain, and they have migrated to the eyes. So that is the reason why we consider these systems when we have any genetic disorder related to hypopigmentation. Second question that we ask is, in addition to melanocytes, which are the other cells that bear similar granules? Because it's the same genes that drive the function of the granules or the melanosomes, whether it's a granule migration, the melanogenesis process. So similar to melanosomes, the similar functioning cells are platelets. They have the dense core granules. The NK cells and the granulocytes, which are a part of the immune system. So that again explains why I said CNS, ear, eye, platelets and immune cells. This is the last picture, which is non-clinical. So another thing that we want to remember, important gene, if you want to remember just one, is to remember mTOR. So mTOR activation, mTOR is basically a pathway that is actually a growth pathway. So the most common disorder which we associated with mTOR will be tuberous sclerosis. It's a loss of inhibition of growth. So what happens is that there is a dysregulation of growth whenever we have these pathway defects. And generally this leads to, we would think, hyperpigmentation, but what actually happens is the melanocytes undergo senescence, the melanogenesis undergoes a downregulation, and there is hypopigmentation. And more than diffuse, usually you inherit one gene and you have a second hit in one specific areas. So you get macules or nevoid areas or mosaic areas of hypopigmentation. And if you'll remember that anything affecting the melanocytes can affect the CNS, it can affect the ear, eye and the immune cells. So that kind of explains what the diseases that we'll discuss later. So genetic cause of hypopigmentation, I have 2 parts. One is the uncommon part, which I'll deal with second, that where you have a diffusely light-skinned baby or the oculocutaneous albinism and its differential diagnosis. But the more common ones that we encounter in our clinic is localized forms. Here I'm going to use localized and mosaic interchangeably, just to remind you that there is a, if it is a genetic localized cause, it's always a genetic mutation or a second hit genetic mutation, whatever may be the pattern. It may not look obviously as a segmental pattern or a Blaschko-linear pattern. Other patterns can be mosaic, other patterns can be genetic disorders. So in this list we have the most commonest one, previously what we used to call ash leaf macules, now we call hypomelanotic macules because they are not always ash leaf. Then you have the nevus depigmentosus, is when a person presents with a small hypopigmented area, which we are not entirely sure which pattern it is. If it is close to the midline or large, we know it respects the midline. But otherwise we just check for blanching and then ignore it. Then you have the hypomelanosophito, where you have obviously Blaschko-linear hypopigmentation all over the body with systemic associations. Again I'll remind, it's the CNS that is chiefly affected with skeletal. Incontinentia pigmenti, diarrhea and Fanconi's. So localized hypopigmentation or mosaic genetic hypopigmentation. I do identify the patterns, but the patterns aren't everything, because sometimes the patterns can mislead you away from what is important. Then after assessing the pattern and the probable cause, we need to decide the relevance. So if you have excluded the acquired causes, vitiligo, Hansen, all the post-inflammatory conditions, what you are concerned is in an infant or a young child, the cosmetic issues and the cosmetic management, if you are planning, will come at a much later date. What you want to do is that, do you reassure the parents? Do you follow up the child? Or do you investigate the child now? Or probably send to a pediatrician? So these are the decisions we have to make. So this is a very small part of our practice. You want to do it efficiently, you do want to do it effectively and fast, so that you can actually reserve the time for the high risk patients and happily reassure the rest of them. So we have in this localized hypopigmentation, these are the disorders I will be dealing with. So how to reach till a conclusion that this is a localized genetic cause or a mosaic hypopigmentation? It is congenital or early onset. Not always congenital, because sometimes the lesions become more evident as the child gets pigmented. Tiny lesions are unnoticed, but they grow proportionately, so the mother notices them later. And in conditions where a double hit is happening, that is like tuberous sclerosis, lesions can appear later also. But it is generally non-progressive. It doesn't spread into weird shapes like vitiligo. It doesn't cause all the other associated cobnerization. It's mostly a proportionate growth once it has appeared. And if large, it respects midline, that makes our work much easier. So now onwards it will be just cases. So this is a 3-year-old male child who presented to OPD. Had been referred from the pediatrician after a routine consultation for these macules. So there are 3 hypopigmented macules. Helpfully they are on one side of midline and they are non-blanching, and I have recorded the size because the child is a 3-year-old, and if you are planning to follow it up, it's better to know how many were there and how many are happening later. So not very concerned, the child was otherwise entirely normal, the pediatrician had already examined. So, but the only thing that was concerning is that the child had a cafe-au-lait macule. So what all was done for this child? So I checked the skeletal system, already checked by the pediatrician as well. Neurology was fine. We did an ocular examination, and after that did an eye examination also. This much was normal. So currently what I was suspecting is the child is being followed up for his tuberous sclerosis. So just one question maybe for the residents in the back. I have 4 images. Here we have a confetti lesions. Here you have a sort of segmental pattern of distribution. Here you have an oblong shape, and here you have an irregular shape. How many of these could be tuberous sclerosis? 1, 2, 3, 4, none. Residents. So the answer is all of them. So that is what I said, do not depend on the pattern. This is obviously why we used to call these ash leaf macules, but we no longer call them ash leaf because the ash leaf is the last shape, this one. So where one end is rounded and the other end is pointed. Both ends can be pointed. The gene doesn't know what we are expecting. Both ends can be rounded. It can be irregular, which we will call a nevus depigmentosus. Segmental patterns are well described in tuberous sclerosis. So our confetti macules are described as a marker of tuberous sclerosis. That is why they are renamed as hypomelanotic macules. And even though the standard teaching is 3 or more are significant, that is applicable to older children. So a young child, even with a single macule, even if you do not have the criteria to screen them immediately, you can keep them under follow-up provided you have other danger signs. As we already said, the rest of the skin examination, the family examination, the clinical examination of the CNS. So when you have white patches, shape is important, not entirely important, but we cannot entirely depend on it either. Number, size, full skin examination for other lesions which may raise red flags like cafe-au-lait macules, a full neurodevelopmental history and examination, eye examination provided the child is cooperative, and family screening. The child is still young, has not manifested most of the diseases. It will be difficult to follow up and examine the child, but it is easy to examine an adult who has manifested the different features. Sometimes we diagnose the child by examination of the parent who is relatively asymptomatic and has a few adenoma sebaceum, has a single Conant's tumor or a cafe-au-lait macule. So they express it more, but the disease can be subtle in some, the disease can be severe in some. And if any red flags are raised, you defer to the pediatrician, and if there is a significant suspicion of tuberous sclerosis, they would directly image. So unlike in NF1, CNS imaging is compulsory. So tuberous sclerosis, a dermatologist's role is early diagnosis and monitoring, and providing supportive care and in collaborating with the pediatrician. And at the same time, avoid unnecessary investigations in low-risk children by not knowing when to evaluate hypopigmented macules. And if you are still uncertain after all this checklist, just gently tell the parent that we can follow this up very occasionally, maybe once in a year, or just meet them during their vaccination visits. So this is another patient. This is actually a young teenager who has very pinpoint hypopigmented macules over the body. And family members also had few guttate hypopigmentation, and this is a nail finding. Later the family members had developed some darker, thicker lesions, but this is the younger patient. So anybody can take a guess? So this is the guttate leukoderma of diarrhea disease. Later when the obvious lesions have appeared, the hyperkeratotic lesions are appeared, it's not difficult, but it is important to suspect and examine in detail at this stage. So this is another patient again who also had a background of diffuse hyperpigmentation, guttate hypopigmentation. Some other patients in the same community with this had just patchy leukoderma which looked like ash leaf macules, and this patient also had a hypoplastic thumb. Any takers for the answer? And this when child later presented with pancytopenia. So this was a case of Fanconi's anemia. So Fanconi's and diarrhea in dark-skinned individuals are well known to have not just cafe-au-lait but hypopigmented lesions of varying patterns. In both of these cases it was confetti, but it need not be confetti at all. Diarrhea is almost always confetti, and Fanconi's is always localized hypopigmented macules mixed with cafe-au-lait in the Indian scenario. So this is another infant who came with this particular pattern. So it doesn't look like a proper Blaschkoid pattern, but it definitely respects the midline. Everybody's sure it's mosaic, but there is some vaguely leaf-like patterns. So this is what is the larger lesions there. It is a phylloid pattern or a leaf-like pattern. So this pattern is important because for most of the patterns we are unsure what is the genetics. We are unsure, we have to screen everything. We don't know the genetics until we test the child's skin separately. But it is well known that when the phylloid pattern is there, it's usually 13q, and it has specific ocular, hearing and skeletal defects which helps you in screening. It's a relatively rare disorder, but patterns do help. So overall picture for diagnosis are these, the checklist that we follow in OPD. Other causes include nevus anemicus. Early epidermal nevi can sometimes appear hypopigmented, but they are slightly raised. Incontinentia pigmenti have their own features, and LSA will have atrophy, not usually early onset, and early segmental vitiligo. So this is a checklist. What is the onset? What is the progression of evolution? What is the pattern? When to ignore the pattern? When to pay attention to the pattern? What is the individual morphology of the lesion? Is it raised, atrophic or blanching? What are the other skin findings? Systemic examination focusing on your major systems that we encountered through the melanocyte migration, the granules and the mTOR pathway. And is it worthwhile to examine the family? Is it worthwhile to examine a genetically similar older person in the family? So this is a child who came with pigmentary dilution. There is a photo with the mother to show how light the child is compared to the rest of the family. I was sort of light brown, and not entirely sure if it is diluted or not, but the hair is definitely light. So it's a 10-month-old male with a second-degree consanguinity, eyes were brownish with global developmental delay and foul odor of urine. And this was the image. If anybody has the diagnosis already. So this was a case of phenylketonuria, and this is a mother's hair for comparison. This is the interrupted medulla. It was not pigment clumping. So this is just to show the approach to a diffuse pigmentary dilution. So we all have seen the algorithm at some point in our academic lives. So, but we don't need to remember the algorithm. The eye involvement may or may not be there. Sometimes it is subtle. What we need to know are the dangerous ones that we need to exclude before we manage the patient in a relaxed way. So the most important I would say is inherited errors of metabolism, PKU, homocystinuria and histidinemia. Here we can, if we diagnose early, the dermatologist diagnoses early or suspects early, diagnosis early, we intervene early, we prevent major morbidity. And this is also another condition where the intervention is a little bit more difficult, but early diagnosis can lead to hematopoietic stem cell transplantation, which is curative. And again, Griscelli is another condition where early intervention is necessary. So this is again a patient with pigmentary dilution, but eyes were normal, had recurrent episodes of major infections in the past year. Peripheral smear was normal, but hair examination showed irregular clumping, which were large and in different parts. So clinically for a dermatologist, this was Griscelli syndrome, but unfortunately during the evaluation, before we could confirm the genetic diagnosis was later confirmed. The child developed HLH and expired before HST could be done. So this child was already 1 year old. The hair and skin had been noted at birth, so it should have definitely been screened earlier. So this is another child with Griscelli who had not presented with immunodeficiency but with neurodegenerative manifestation with similar finding. Again, the child was relatively old, but type 1 doesn't have very effective interventions. So this is a 16-month-old female with second-degree consanguinity, sensory neural hearing loss, seizures and hyperactive. So again, we are focusing on the red flag areas of our algorithm, and naturally I found something which I could fit with this, that is Angelman's or phenylketonuria. But again, the patients always prove you wrong. This was a non-syndromic oculocutaneous albinism. Probably due to consanguinity or endogamous, there were multiple homozygous and heterozygous defects. There was tuberous sclerosis. Sensory neural hearing loss was due to another gene, seizures was due to this, and the skin was isolated due to the OCA. So things can be unexpected. So the takeaway point is diffuse pigmentary dilution screen at birth or ASAP, and sometimes you can help. So screen for inborn errors of metabolism, and hopefully in India the dried blood spot at birth will become uniform. Then it will not be a big concern to us, but it is still available in different centers. But if your child, your infant or neonate is pigmentary diluted, do consider consider sending the dried blood spot for tandem mass spectrometry for the screening test for inborn errors of metabolism. Before the if you diagnose early, you start nutritional management and prevent CNS abnormalities. Do a peripheral blood smear which can diagnose Chidiac-Higashi and platelet disorders in Hermansky-Puttak, and hair shaft microscopy which can give you an early diagnosis of Griscelli and Chidiac-Higashi, but Chidiac-Higashi isn't that common in India. So these are my references, and these are my takeaway points. That is, if it is localized, do not forget tuberous sclerosis, and if it is disseminated, consider screening at the earliest with the trio of blood, hair, and inherited errors of metabolism. Thank you for your patient listening.
Thank you, Dr. Irani Matthews. Any questions from audience? No, thank you.
Thank you so much, ma'am, for this wonderful session. I would request our chairpersons and speaker to kindly collect their mementos. Next up, we have a panel discussion. I would request Dr. Rizwana Barkat, ma'am, to kindly moderate the session.
Good morning, everyone. Today I'm going to moderate a panel on the topic vitiligo management, what, when and why. And for this discussion, I would like to call upon the stage our esteemed panelist, Dr. Siba Hussain ma'am, Dr. Ravi Vikram sir, Dr. Rajnish sir, where is he? Yeah, Dr. Punkesh Kumar sir, Dr. Shubhra Datta, and Dr. Gobind Kumar. Yeah, so all the panelists are present here. So without delaying much of our time, now I'd like to proceed with our discussion. Should we start? All the panelists are ready? Yeah? Okay, fine. Vitiligo management. Actually, I've prepared the slide considering the postgraduate students sitting here. So the questions are very basics, like daily OPD cases. So kindly listen carefully, especially the postgraduate residents. Yeah, this is the first case. A 42-year-old male with multiple depigmented patch over trunk and extremities since 5 months. Progressive in nature. Now, what are the investigations you will do in this case? So, Dr. Gobind, how will you take this case?
This clinically looks like generalized vitiligo, but we'll access by other investigations, like we can do Woods-Lamp test to rule out our differentials. Like if there is association, then it will be vitiligo. Otherwise, it can be a PMH also, progressive macular hypomelanosis. It can also pityriasis versicolor, many other things. And other test, we can also do some tests like for baseline investigation to start our therapy, like complete blood count and LFT, KFT, like that.
Dr. Shubhra Datta, how would you take this case?
First of all, we would completely examine the patient and identify all the sites involved, and we will, as sir has suggested, Woods lamp examination will do to confirm our diagnosis and rule out all the differentials, and then we could have a baseline VASI score before starting the therapy, and also in the blood test that is involved, if the disease is progressive, we can also screen the patient for thyroid antibodies because autoimmune association can be present.
Yeah, Dr.
In this
Shivani.
case, as the age is important, a 42-year-old male. So from this age, we can consider many of the metabolic diseases. My first priority will be to evaluate and take consultation from our medical OPD and then do our treatment. Thank you.
Yeah. Any other panelist would like to add something in this? Dr. Rajnish?
As told by other panelists, apart from the basic routine investigation we should do, like the CBC, the thyroid profile, blood sugar, fasting, H1AC, to rule out the comorbid conditions like diabetes, because on management we may put this patient to oral steroids. So before starting that, we should know the baseline status of
Any other
diabetes.
autoimmune disease which you would like to consider apart from thyroid?
Yes, we can go for a vitamin B12 investigation to rule out pernicious anemia, and
vitamin D3 deficiency also may lead to.
Yes, ACTH also we can do.
Yeah, for Addison's. Yes. Yeah, for Addison, considering Addison. Yeah.
See, it's quite obvious that it is. First, you have to classify. It's vitiligo. You have to classify, and then according to classification, you have to do certain things. So this is progressive non-segmental vitiligo. Now this it is progressive, hai na? So one aspect of investigation is it's usually sometimes associated with other autoimmune diseases. So investigation should be for that. Then mapping how much of the extent is there. Photography is very important for follow-up. Then, because you have to put the patient on immunosuppressive or immunomodulated drugs, then certain investigations have to be done prior to initiating that. So this is basically classification, mapping, and then investigation to rule out certain associations, and investigation for suitability of patient for the treatment that you are taking, and then follow-up tests, whatever is required, right?
Punkesh, would you like to add something in this?
No, everything is covered by our panelist.
Okay, so very well described by our panelist regarding the investigation. Very well said that yes, three things we have to see. First, we have to confirm the diagnosis. Second, we have to see the extent, how much body surface area is affected. And third is we have to detect the autoimmune disease. So these are related to disease. Now, if we want to investigate related to treatment, then we have to go for further more investigations. So related to disease, there are already said like Woods lamp examination, VASI assessment we have to do for body surface area involvement. Then yes, clinical photograph is very basic thing, which I think most of us, even when I was preparing this slide, I was not having sufficient photographs of vitiligo cases, though I'm having many photographs of rare cases and many atypical cases. But for vitiligo, we don't used to take routinely a photograph. But yes, it is important to look for in the follow-up that whether patient is being benefited with the treatment or not. Screening for autoimmune diseases, yes, pernicious, Addison, diabetes and thyroid, these all should be investigated in these kind of cases because non-segmental are more commonly associated with autoimmune diseases. And yes, very well said by Dr. Seema Hussain ma'am that yes, age, considering the age of the patient might be having some metabolic disorders, so we have to screen it. Everything has already been discussed, so come to the next question. How will you manage this case? Dr. Punkesh.
First thing, we should assess the activity of the disease. Is it stable or it is active? If disease is active, first thing we manage, we halt the progression of disease. Because if disease is progressive and we can't do enough treatment for that things, situation go worse. So first thing is the stability, and then for repigmentation. And the first line of drug is always narrowband UVB or light therapy like PUVA or PUVA-SOL treatment. And for activity halt, we can go for short course of steroid or pulse dose of steroid. If there is contraindication, then we can go for some other immunosuppressive drugs.
Any other panelist would like to add something? Dr. Rajnish, would you like to add something?
This patient, I think counseling is very important. In my OPD, I feel bad for some patients, especially female. We do give, but they still wanted to get better and better. A lady had come few days back only. and somehow she landed up in our college, and I told her, I am with you, but the only thing that the patches might get reddish, but concentrate on your neck area and hand area, forget the abdominal area. She was convinced, and I asked my student to start the dose and gave her all the supplements, methotrexate and the basic. So I think counseling is very important, because we sometimes feel for the patient.
In this patient, I would like to, as sir has suggested, narrowband UVC. Apart from this, since the disease is progressive, we can add oral mini pulse, betnisol, betamethasone 0.1 milligram per kg body weight, depending upon 2 days in a week, and we'll continue it till the disease is stable.
Dr. Shubhra, anything you would like to add?
As ma'am has already specified that counseling is very important in patients of vitiligo, because they're already very stressed, and it's a vicious cycle that goes on. It triggers the activity of the disease also. So counseling, and other than that, oral mini pulse is my first go-to therapy that I use for my patient. Topical steroids, tacrolimus, and these therapies only, and phototherapy.
Anyone who would like to add something in these management?
I think I would like to summarize what has been said, that there are two aspects of treatment. One is arrest of progression, the other is repigmentation. Both should go hand in hand. Yeah. What is the choice of drug depends on many things. The pre-existing comorbidities, previous treatment history, how fast the disease is progressing, and what amenities you have, what he can afford. These things basically help the clinician to select a particular regime for a particular patient. That's it. And counseling always, in all skin cases, not only in skin cases. When a dermatologist has to be a counselor also, in most of the cases.
Very truly said, sir, because most of the disease are going to come back. Yeah, so in the treatment, very well said by the panelist, that we have to divide the treatment in two things. First is arrest the disease activity if the disease is active, and second is repigmentation, and both the things should go hand by hand. This is very true. So in systemic management, everyone said about systemic corticosteroids. Other systemic immunomodulators we are having in options are methotrexate, azathioprine, cyclosporine, MMF, and tofacitinib, JAK inhibitors. I haven't focused many on JAK inhibitors, because I think yesterday already JAK-I has been discussed very much, more than enough. So I haven't mentioned this in my slide very much, okay, about JAK-I. Topical treatments, corticosteroids, calcineurin inhibitor, methotrexate, JAK inhibitor. Ruxolitinib, I haven't used till now, because as I feel that it's not available in India, but yes, it's in studies it's showing a very good result. I have gone through few studies and it's showing very good result, and in some studies it is saying that it is going to replace corticosteroids and calcineurin inhibitor. So any of my panelists who have any experience with ruxolitinib? No. No, because yesterday while discussing JAK-I panel, someone was saying that they were using ruxolitinib. So I just wanted to know that, whether you people have used or not. Okay. Phototherapy, phototherapy is always very important for vitiligo cases until it is contraindicated. But yes, for narrowband UVB, many dermatologists are not having. Light therapy, many dermatologists are not having. So for this, I think Puvasol is a good option, considering the population of Bihar. Like poverty is very high here, so patient can't afford also all the patients. So Puvasol is a good option for those. One thing is that sun protection, I think we should ask our vitiligo patients, because vitiligous skins are more prone of getting carcinoma. So I think many of us don't recommend sun protection in vitiligo patient very routinely, as we used to do in melasma and hyperpigmentation patients. So that should be considered in a treatment point.
At this point, I want to say one thing. I got to know from the patient itself. When I met her, she told, I am Puva, she knows, because it's a chamber. Yeah. She does not know the language. एक कमरे में हम जा करके लाइट लेते हैं. हम बोले कहाँ? तो she told about, and I won't name, a person. तो आजकल क्या हो रहा है? Being a dermatologist, I was shocked. But पैसा खरीद करके वो लोग एक chamber रह रहे हैं, and they inviting patients. आओ लाइट लो. I was shocked, because as a dermatologist we have to combine Puva therapy along with many other indications. So by one person I met, It could be happening in whole Bihar, I think so.
Might
So
be
we have to be
maybe.
very careful in taking the history, because doctors, they buy up PUA chamber and keep it in their clinic, and they come 500 rupees or 350 rupees unka session rehta hai, and they give PUA therapy and the patient goes. And they are very happy. As a dermatologist, if we ask, they say, हाँ कमरे में तो हम गए थे, light दिया था doctor. What I was shocked.
Okay. Yeah, and psychological counseling is very important. Now coming to our next case, 28-year-old male on tofacitinib 11 mg tablet daily since 7 months. There is no new lesion since 2 months, but the patient is unhappy with the slow repigmentation of the existing patch. Now, what is your approach in combining narrowband UVB with other treatment? Does early combination give better repigmentation versus sequential therapy? Dr. Govind.
Yes, early combination therapy will be beneficial for the patient in both repigmentation and stopping the progression of the disease, because we can give like short course of corticosteroids along with PUVA therapy, NVV be targeted, or NVV chamber, and other we can also combination will be better for them.
Better. Yeah. Any panelist would like to add something apart from this? Any panelist who believe that no, early combination should not be given, we should wait for sequential therapy, is it so? Combination, always good, na? Okay. So let's move fast because we are having only 15 minutes now. Yeah, early combination of narrowband UVB plus another therapy definitely gives faster and often better repigmentation. Now why combination works better? Because it gives a synergistic effect. Now narrowband UVB stimulates melanocyte proliferation plus migration from hair follicles, migration of melanocyte from hair follicles. And apart from this, the topical treatment or systemic treatment which we give, those acts on the local T cells and interferon gamma. So together both of them stop the attack and stimulate the growth, repigmentation. So definitely there will be faster onset of result. For patients requiring long-term phototherapy, what is the optimal frequency, duration and strategy which you people used to follow in your daily practice? Dr. Punkesh.
Definitely narrowband UVB works well with other modalities. One thing is for patients who require the long-term, of course, phototherapy needs a time. Literature says 120 dose or 150 dose is total cumulative is 120 or 150. But in our scenario, in our patients, we require more. Even I asked few days before sir कि sir हमारे यहाँ पर I asked Ravi Vikram sir कि sir हम लोग कितना दिन दें? Sir बोले हम लोग देते हैं. Literature में जो long term side effects है like carcinoma हमारे यहाँ कम है. Then we can go for long term narrowband or phototherapy.
Carcinoma हमारे यहाँ कम है in Indian population definitely, but at vitelliginous patch carcinoma is common. Considering that, do you prefer we should give for a longer time?
We can always assess the lesion, follow up the patients. So can we monitor the things better?
And
because
after complete repigmentation, sir, do you prefer in your patient to give phototherapy in maintenance dose? After complete repigmentation?
Yes, for maintenance dose, weekly or bi-weekly for 6 months. For 6 months only. For 6 months.
Okay. Yeah. Anything? Nothing. Okay. So for repigmentation, like before achieving maintenance, before achieving complete repigmentation, the induction phase frequency, which has been mentioned in the literature, should be 2 to 3 times per week. And duration we should continue until plateau. Plateau arrives approximately on an average 23.8 months in adults and 14.8 months in children. Children repigments earlier. Dose is 250 millijoule per centimeter square for adult, 150 millijoule per centimeter square for children, with 20% increments, and maximum we can go up to 1500 millijoule per centimeter square for face and 3000 millijoule per cm square for body. Though we don't follow this routinely, but I remember that in Gaya Medical College we have calculated the cumulative dose while giving phototherapy in our patients. We used to calculate, as I remember. And for maintenance therapy, yes, after plate tube, we have to give a maintenance therapy or phototherapy to the patients. First month, according to as per literature, 2 times per week. Bi-weekly we can go. If still there is pigmentation, no disease activity, second month, shift to 1 time per week, that is weekly. Third month, once every alternate week. And if till 4th month there is no disease activity, you can stop as per literature. But yes, very well said by our panelist that in some of our patients we require very longer duration of period. So we have to examine for carcinoma and any early skin changes over the vitelliginous area or the treated area. Case 3. A 7-year-old boy, 3-month history of well-defined depigmented patch over face, unilateral following a dermatomal pattern. Now, how do you differentiate segmental versus non-segmental vitiligo, and is segmental always a neurogenic case? Yeah, Dr. Shobhra Datta.
First of all, is segmental always neurogenic? The theories, according to the neurogenic theory, it was that the melanocytes, they migrate in the dermatome, but according to this case that we have seen, it is not necessary that it is always dermatomal. Yes, it is respecting the midline margin, so we would preferably want to call it a segmental vitiligo. The difference is that, of course, it respects the midline and the non-segmental does not, and especially it is the segmental vitiligo is more common in the younger age group, and it is very rapidly progressive. The response to therapy is not so good, but it stabilizes also. So these are a few takeaway points.
Yeah. Dr. Shiba ma'am.
Since the boy is 7 years, but we should not jump to any treatment, in my opinion. We should have a regular follow-up, monthly follow-up, and see the pattern. Because in child, we might land up in trouble. So before starting any dose, according to our dermatological references, we should, I think, make the patient, at least in my opinion, 3 months I would ask him to come on monthly basis and then plan a mode of treatment, because the person is a child. So I won't jump into any type of steroid or
no, ma'am,
application.
But my question is like, do you feel that segmental is always a neurogenic case? Is it so?
No.
Any other panelist who would like to add something?
See, most of the literature and published articles say that it does not respond to normal what we give vitiligo treatment like that. But in my experience, at least 50 to 60% of children who have presented like this have responded very well with conservative treatment. Anyhow, we never expect all the vitiligo cases to respond. Similarly, in segmental also, or especially this one, which is more blushcoid than dermatomal, it gives a very good response with conservative treatment also. Maybe 100% pigmentation might not be achieved, but 70 to 90% pigment is achieved. And follow-up, usually the pigment stays. A few patches which do not repigment by conservative treatment might require grafting and all those things. But this is also amenable to treatment, as far as my experience goes.
Yeah, but sir, as we know that yes, segmental, very well said that it responds good in many of the cases. But in many of the cases, it has been seen that after achieving a certain amount of repigmentation, little bit of depigmentation is left out, and that doesn't respond at all. So in those cases, what you will prefer?
Especially in child, there is a lot of psychological burden, peer pressure and very heckling and bullying. So that aspect has to be taken care of. So if it is not responding, say in 6 months, 1 year, then should go in for grafting or suction.
That means for surgical option you will proceed.
It responds very well, and usually the treatment is very successful in that case.
Okay.
Right.
Should psychosocial impact be considered an indication for earlier systemic or advanced therapy in children? Yeah, Dr. Punkesh.
Definitely. The psychological impact of child is very embarrassing for us also. And we should go for early treatment if disease is stabilized and there is no other contraindication for surgery. We can go for early treatment.
Okay. So, Dr. Rajnish, would you like to add something?
If after giving the medical therapy for for a prolonged period of time, even the pigmentation is not there, we can plan for surgery, and suction blister, as sir mentioned, is a good option.
So, Dr. Shivani ma'am, would you like to add something in this? No. So, like considering the psychosocial impact, you people will prefer that yes, we should start the treatment as early as possible. Okay. And management, as already Ravi Vikram sir said about surgical, any panelist who would like to add something apart from conservative and surgical? Management in this case only, segmental.
Excimer can be given.
Phototherapy.
Yeah,
phototherapy. Okay, yeah, good. Phototherapy can be given, truly say. So these are the differences between segmental and non-segmental vitiligo. As per symmetry, segmental is usually unilateral, as said by Dr. Shobhra Datta. She already mentioned all the things: progression, stabilization. It tends to stabilize earlier segmental as compared to non-segmental. Recurrence is also very lower in segmental cases. One thing which is very common I have seen, that leukotrichia is very commonly seen in segmental cases. And that is a very important thing why segmental responds poorer to treatment, because the hairs are also white. So that comes under a poor prognosis for repigmentation. And autoimmune association, as we have seen in vitiligo cases, but in segmental it is almost nil. I haven't seen any of my segmental case associated with some autoimmune diseases. And as per literature also, it is very less frequent. Family history is also very less prominent. And medical treatment is very less responsive in segmental, as because of the one thing, leukotrichia is a very bad prognostic sign. So that could be a reason. And surgery gives very good result in segmental. Management, definitely in childhood vitiligo, treatment should be tailored to avoid negative effects on overall growth and psychological development of the patient. Because if the vitiligo is on exposed area, then the child may refuse to go to school. He may refuse to go to markets, and outdoor activities he may reduce to do that. So that can again lead to various other diseases. Also, that psychological issues can lead to triggering of vitiligo, as said by our panelist also. So treat the child, not just the patches. And don't wait for 20% body surface area in these kind of cases. If child is having facial lesion, if he is having some bullying condition, age more than 9 years, and child is declining school performances, then escalate earlier, don't wait. Vitiligo significantly diminishes quality of life and heightens risk of concurrent mental health issues. So earlier repigmentation will lead to less cumulative psychosocial damage. Segmental is the best for surgery, as already discussed by our panelist. Among the surgical options, we are having non-cultured epidermal cell suspension, which are giving a good result. Then melanocyte keratinocyte transplant also, that works good on face and lips. Suction blister grafting, but yes, it is for very small patches. This patch looks bigger, so suction blister would be a troublesome technique for us. Then skin thickness grafting also works on these patients, but yes, younger patient with dark skin segmental type gives better result, and mainly for facial lesions. Miniature punch grafting usually not preferred over face because of the cobblestone appearance, so very less preferred over the face. Case 4. 35-year-old woman has vitiligo involving more than 80% of her body. She has undergone multiple unsuccessful attempts at repigmentation and requests complete depigmentation for cosmetic uniformity. How will you manage this case? Dr. Shivani ma'am, can you take this?
For this patient, full counseling is the only option. Nothing I can think.
Okay. Yeah, Dr. Shobhra Datta, would you like to add something?
Theoretically, the monobenzone is used, MBEH, which is.
Did you came across with these kind of case till now in your practice?
Yes, 1 or 2 patients I have seen, but I have not used the
yeah,
drug.
exactly.
Counseling.
When I also
ma'am
got
said.
stuck, then I started studying that how we have to give.
Theory says that, but we have not used it practically. But that can be used for tattooing and camouflage. But then this is a very large area, so it's very difficult.
Dr. Gopal.
Same thing when counseling is important. And never used monobenzone.
Ravi, Vikram sir, would you like to add something, sir, in this case?
See, basically we should go in for permanent universal depigmenting procedures, interventions, when the area is more than 90% already covered by vitiligo and treatment has failed. So you have to document all these things. The treatment history, the photograph, why you are going in for that, then consent of the patient that she has demanded. This is very important. Now, monobenzyl ether of hydroquinone or benoquine is a very good molecule, but it requires a careful handling. So commercially it is available in 20 to 40% preparations. What I do is that I select a patch, especially over face first, a small area, say old 1 rupee coin area, and apply it there overnight for 10 days. Then wait for 20 days. Result comes later.
Yeah.
Or in 10 days, reaction occurs. If the person reacts, take the history whether sun exposure had occurred, or if sun exposure had occurred, ask her strictly to avoid sun exposure, then reapply it at another site, see whether reaction occurs or not. So first initially you apply overnight for 10 days only, wait for further 20 days. If it works, it might work just in 10 days, the result might show in 20 days. If it doesn't, next month you continue for 20 days, once a day, then wait again for 10 days. So in this way, you can reduce the amount of drug that you are applying, you are testing also, and you are finding out whether it is working at a later stage. Now, once it has started working, you continue with the regime that has worked, with minimum application. Usually twice a day application is not required. I have treated around 20 to 30 cases with this, what I am telling you. So over a period of time, go on depigmenting, you can take one site at a time, especially the exposed areas, with strict avoidance of sunlight and strict use of sunscreening and protective clothing. So once the depigment is achieved, you advise that again you have to use sunscreen and avoid sun exposure strictly. If pigmentation reoccurs, you can go on with the same regime, but always under supervision. Always ask the patient to come every 1 month or 20 days so that you can control the amount of drug being applied and see for side effects and the results, so you can titrate the treatment properly according to the needs of the patient.
Any counseling which you would like to do in your patient while treating these type of cases? Any particular counseling apart from irritation and all those things? Any particular counseling?
Counseling, I think, is an important thing. One thing is, if you use monobenzyl ether or TC or phenol, there is chance of scarring. So always counsel patient for the scarring, and always apply in the supervision only. Don't give the patient TC or phenol.
Counseling in the sense that once I said that you have to take the consent of the patient, is that you should have to explain that the result achieved will be almost irreversible. If she wants that again repigmentation to happen, that won't be happening. So this is very important. That's why you have to take the consent, writing all these things, that yes, she has understood or he has understood and he is giving the consent for that, right?
So in this case, like, first we have to assess, we have to confirm that yes, body surface area is involved more than 90% and it is stable for more than 12 years. Then documentation is very, very important, as very well said by Ravi Vikram sir, that in this case we can suffer with legal issues also if we are not going to take informed consent, signed consent from the patient. So we have to take an informed consent undersigned by the patient and explaining the irreversible nature of the treatment. one thing which I found in some of these studies, that we should counsel our patient for repigmentation also. That in some patch, although after certain years, these patch may repigment spontaneously with sun exposure. So that should also be kept in. Although the literature mentions that the results are irreversible, but in some literature, though I have having a very short experience with these type of cases. But Ravi Vikram sir, as he said that he already treated these kind of 20 to 30 cases, so I think that he's best to deal with these type of cases to say about this. But have you seen, sir, that repigmentation occurs?
Sometimes does occur.
That's
why sun protection is very important. If it reoccurs, then you can go ahead again with the same regime.
Go ahead, yeah. But at that time, like if we will not tell the patient, then the patient will come back and fire at us that I have paid for depigmentation, why it is repigmenting. So that's a very important point. Document is very important, yeah. In this case, actually, documentation is very, very important. That's why I have put this case in the slide. Side effects already discussed by everyone, so I'm not going to maintain. Topical agents already discussed. Other methods like lasers and cryo, have you been used? No. Okay. In some literature, it mentions that lasers and cryotherapy also helps in depigmentation. Yes, cryo can definitely help in depigmentation. Lasers, for this case, I have no idea, but yes, as it was mentioned in some JAD articles and BAD articles, so I've just put it in my slide. Last question. What are the new topicals beyond steroid? Sivashan ma'am. Any new topicals beyond steroid for vitiligo?
As ma'am, you have already told, ruxolitinib 5%. Other than that, some prostaglandin inhibitors like bimatoprost.
Those are under pipeline.
Yeah, it's under pipeline because it was observed as a side effect of glaucoma treatment.
Correct. I have also read that article, I think.
Yeah,
okay. Any other? Yeah, tacrolimus, but sir, I think that it's no more new. No, new topicals, I'm saying.
Prostaglandin analogs may be used.
Yeah, prostaglandin analogs.
Topical tofacitinib also.
Tofacitinib also, correct. Any panelist would like to add something in this?
My experience with topical tofacitinib has been very, not encouraging. Topical tofacitinib.
Tofacitinib, okay, yeah.
But in my cases, somehow it has not worked, even as the third adjunct.
Okay.
So, Rajnish must be having some experience.
No, even we are also using, but we are also just trying to get the result. So it's, I think it will be too early to say that.
Tofacitinib and tacrolimus I find working better. And of course, in acral areas, neither steroid works good nor tacrolimus.
Acral area is very, very difficult. Right. Okay, so these are the newer topicals. Topical ruxolitinib, yes, we are reading but haven't used till now. Don't know when it will be available in India so that we can use it. Topical tofacitinib and ruxolitinib and tofacitinib, the main difference is that ruxolitinib blocks JAK1 and JAK2 both, whereas tofacitinib blocks JAK1 and JAK3. So, and other are delgocitinib. It is also emerging under investigation. Few which are in, now this delgocitinib is pan-JAK inhibitor. It inhibits all JAK, JAK1, JAK2, JAK3. And then under pipeline, there are topical basic fibroblast growth factor and prostaglandin analogs as said by the panelists. And yes, melanocortin pathway agonists are also under study. So these are in pipelines.
There is one new molecule. There is a molecule preparation known as PhotoFirst.
Correct.
But I was very skeptical about the principle. Very skeptical about how it works initially, and then I use in 1-2 patients just to try it out, but it doesn't work at all.
Yeah, because initially they have promised very much while advertising, but even I have also not seen any good result of that. That's why I haven't mentioned also. Okay, so with this I would like to conclude my session here. And thank you very much to all the well-grounded panelists. Because of them, at least I was able to learn vitiligo very much. Since last few days I was reading vitiligo because after seeing the panelist list, I was very much nervous that whether I'll have to answer the questions because they all must be knowing all the questions. So at least I was able to learn the vitiligo some new topics. Thank you.
Thank you so much, sir and ma'am, for this wonderful panel discussion. I'd request our moderator and panelists to kindly collect their mementos. For the next session, I would request Dr. Anjishnu Prakash sir and Dr. Shashank Shekher sir to kindly chair the session.
Hello. Now I invite Dr. Swetalina, Associate Professor and HOD, AIMS, Dermatology Department, Patna.
Very good afternoon, everyone. So this is basically the sponsored session by Novartis. So the slides are of Novartis. That is mostly now we have a urticaria. We know chronic spontaneous urticaria. It is not curable. Whatever we give patients, we always counseling is the, I think, the best treatment. And most often we counsel the patient that urticaria, this is a chronic in nature like diabetes, thyroid, you have to take medicine for longer period of time. So patients are usually mostly dissatisfied with the treatment. They hop and hop one dermatologist to other, one hospital to another so that they can find a cure in chronic urticaria. So after this presentation, so as the claim by this Bruton tyrosine kinase pathway, which is the pathway which controlling the three cells which will ultimately lead to almost cure of urticaria. So the drug remibrutinib, which is being claimed Bruton tyrosine kinase pathway inhibitor, that is still in trial. I think it is phase 1, phase 2, phase 3 is completed. Now phase 4 trial is going to be conducted in India, pan-India. But however, it is not available in India, but Novartis is providing the drug by the session. They have a, if you, by the doctor will tell this patient is not responding to any antihistaminic omalizumab, you have to request for the drug, so you can get for any patient through Novartis management access program. So I'll be speaking on the what is the unmet need of urticaria currently we are facing. So this is the disclaimer, and so coming to chronic spontaneous urticaria, that is spontaneous appearance of wheals, angioedema or both more than 6 weeks of duration. So this urticaria can affect any part of the body, and it is mostly itching and burning sensation, and usually lasts less than 24 hours. So women, it is twice common in women compared to the males. And it impacts primarily people working age of 20 to 40. It has been seen it is more common in age group of 20 to 40 years. And almost 2 of the 3 patients of chronic spontaneous urticaria experience angioedema, while 13% experience only angioedema. So it is a debilitating disease with high worldwide prevalence around 1.4%. So chronic spontaneous urticaria has no trigger. So this is the urticaria in nutshell classified acute and chronic urticaria. Under chronic we have inducible and spontaneous urticaria. So inducible urticaria can be physical or non-physical, that is cholinergic aquagenic urticaria. And spontaneous urticaria, so we have some unknown causes and known causes like autoreactivity. So chronic spontaneous urticaria is the most common subtype of chronic urticaria, affecting 60 to 90% of the urticaria cases. So this is the burden of urticaria. So once a patient is having chronic urticaria, it has a affects the personal life and the social life of the patients. So they experience mental and emotional distress, affect negatively the daily activities and functioning, leads to loss of energy, leads to sleep disturbances, negative impact on social life and intimate relationships, leading to direct or indirect healthcare cost and impact the professional and academic life of the patients. So it has a high prevalence of psychological comorbidities, sleep impairment, and significantly affects the quality of life of patients. So what is the unmet needs, that is existing gaps with management of chronic urticaria? So this is the guideline of urticaria management. That first line is for second generation antihistaminic. So we can escalate up to QID 4 times. After that, it is not controlled, we give omalizumab. Then if it is not controlled, we give cyclosporine. This is the guideline of urticaria. However, in India, first we usually give first cyclosporine, then at last omalizumab, because of cost factors with the omalizumab. So goal of treatment is to treat disease until it is gone as efficiently and safely as possible. So treatment goal, so this is for research purpose, because in when we objectively measure the improvement, we calculate US score and UCT score. So treatment goal as defined by the guidelines is to aim to continuous US70, that is complete absence of itch and hives, or UCT, achieving UCT 16, and normalization of quality of life. So if it is UCT score less than 12, 12 to 15, or 16, 16 is complete control, 12 to 15 is well controlled. So if less than 12, it is uncontrolled. So if it is less than 12, so you have to step up, you have to increase the dose of antihistamine. If it is not controlled, then go to omalizumab or cyclosporine. And if it is well controlled, then continue therapy, then optimize the treatment. If it is completely controlled, you can follow the step down approach. So most of the time, even updosing of second generation H1 antihistamine leads to insufficient response. I think majority in the room will agree. So most of the patients we do get cases who tell, even you are giving QID dose of antihistaminic, still I am getting urticaria. So many people do combine antihistaminic one with another, like somebody give levocetizine bilastine, levocetizine fexofenadine. Actually guideline doesn't say that. So you have to give a single antihistaminic and you have to updose it. So this is these are 2 studies, that is QO study from Export Center, and this is urticaria voice study survey, that is self-reported, which the study concluded 6 to 25% of patients achieved complete control when increasing the dose of H1 antihistamine. That is only 6 to 25%. Rest of the patient had difficulty in controlling the urticaria. So that means chronic spontaneous urticaria remains uncontrolled in substantial proportion of patients with chronic spontaneous urticaria despite the treatment with the guideline approach or whatever the physicians combined approach. Still we have subset of patients which have no control of the disease. So treatment target is mostly H1 receptor or IgE, which block the production of inflammatory cytokine. So this is a urticaria pathogenesis the diagram. So we know in urticaria the major cell is the mast cell. So mast cell degranulation releases histamine release, which leads to urticaria. So whatever the cells which are directly indirectly linked, which lead to the mast cell activation. So H1 antihistaminic, so this block the histamine, and so they block the action of histamine, leading to stoppage of urticaria. So next is omalizumab. So omalizumab is biosimilar, which is anti-IgE antibody, binds to IgE, preventing IgE interaction with the FcRI receptor, leading to the activation of mast cell, V cell, or basophil. So that's how omalizumab acts. The cyclosporine, you know, it is a immunomodulatory agent which blocks the T cells by blocking the production of inflammatory cytokines. That's why, so it is add-on for the patient who remain symptomatic even with antihistaminic omalizumab. So last we give as per the guideline cyclosporin. This is in nutshell which it is there in the book, how H1 antihistaminic, omalizumab and cyclosporin acts in urticaria. So significant unmet need with commonly used current therapies beyond antihistamine, that is even with, we do not give methotrexate. I think some people practice methotrexate. So our target is mostly cyclosporin and omalizumab after failure of the H1 antihistaminic. So cyclosporin, it is particularly beneficial in type 2B urticaria, and that is auto antibody mediated. So type 1 is anti-allergic. So cyclosporin you cannot use lifelong because urticaria is a long-term treatment. So it has itself has a this one hypertension, all of many side effects. So we can use maximum recommended duration is 3 to 6 months of cyclosporin. Omalizumab approved second line treatment. It is mostly type 1 urticaria, type 1 endotype, that is autoallergic IgE mediated urticaria. So it has no, we cannot say the patient कितना दिन देना है. Patient first कितना दिन, ये तो बहुत costly है, कितना दिन लेना है डॉक्टर साहब. We have no answer how long we are going to give omalizumab. So there is no fixed limit. This is the summary of unmet need of urticaria. Only 25% of patients achieve complete control when updosing the H1 antihistaminic. Current therapies beyond H1 antihistaminic have some substantial limitation like cyclosporin and omalizumab. So there is a clear unmet need for faster, more effective, safer and endotype agonist treatment. So there comes a Bruton tyrosine kinase pathway in chronic spontaneous urticaria pathogenesis. This is how chronic spontaneous urticaria has a complex pathophysiology involving the major is the center is mast cell activation, releasing of histamine. How the mast cell is getting activated? So Bruton tyrosine kinase pathway, you can see this is the, this slide I have previously shown how urticaria occurs. Now we go to Bruton tyrosine kinase pathway. It's a TEC family kinase central to immune regulation. So it is a cytoplasmic non-receptor tyrosine kinase from TEC family. It is important mediator in the B cell receptor signaling cascade and therefore integral to the proliferation, differentiation, normal development and survival of B cell. It is present in basophil, it is present in V cell, it is also present in mast cells. So it is almost present in all bloodlines, but we have a 3 target in urticaria, that is mast cell, B cell and basophil. So this is how it has played a central role in relaying extracellular signaling to multiple downstream pathway. So you can see the all the, so if it is taught, it has, if it is in B cell, it can be used in multiple sclerosis. So it has a Fc gamma receptor, it is a different hidradenitis suppurativa. It has a multifaceted function because it has a multiple pathway, it is a part of a multiple pathway. So coming to the urticaria pathway, so how the mast cell activation. So mast cells are key cells for chronic spontaneous urticaria. They are either activated by Ig antibody against the FcRI receptor or IgG antibodies against IgE. So mast cell activation leads to histamine release in urticaria. So how basophils are related to urticaria? Basophils are also source of histamine and expression of high affinity receptor for IgE. So when the IgE gets attached to the receptor in the basophil, so it leads to activation, thereby leading to histamine release. So again to the B cells. So this Bruton tyrosine kinase mediates autoimmunity in the B cells. So once the B cell is activated, so it leads to activation of B cell, Bruton tyrosine kinase activation leading to indirectly. So this is a complicated pathway. So you can go through the diagram to understand it better, leading to B cell proliferation. So you can see here there is a basophil. I think this pointer is not working. So is it this chart, center is the mast cell, one is eosinophil, basophil, here is the B cell. So all the cells have Bruton tyrosine kinase pathway. So indirectly, ultimately, when there is a activation of Ig gets attached to FcRI receptor leading to the main pathway activated is the Bruton tyrosine kinase pathway. So here is the Bruton tyrosine kinase pathway. Mast cell has Bruton tyrosine kinase pathway. B cell also has a Bruton tyrosine kinase pathway. So this pathway activation ultimately leads to release of histamine and urticaria. So if we block this pathway, so all the 3 cell lines are blocked, which are the central role in pathogenesis chronic spontaneous urticaria. To summarize, in chronic spontaneous urticaria, not only mast cells but basophils, B cells also play important role in histamine release and generating autoantibodies. So both the endotypes, so chronic spontaneous urticaria, 2 endotypes, type 1 is allergic, type 2B is autoimmune. So they ultimately activate the FcRI pathway and lead to both may also, so one patient might have type 1 or type 2B, or they can occur simultaneously in any patient of chronic spontaneous urticaria. So as I showed in the diagram, Bruton tyrosine kinase pathway is a crucial in this intracellular signaling pathway irrespective of type 1 or type 2. Whatever it may be, chronic spontaneous urticaria, all the pathway common is Bruton tyrosine kinase pathway. So this is the, in nutshell, this slide shows the pathogenesis of urticaria and central role of Bruton tyrosine kinase pathway. So the main is we have a Bruton tyrosine kinase inhibitor, which is not available currently in India. In India it is in trial, Ramibrutinib. So if you give Ramibrutinib, so it will block the Bruton tyrosine kinase in this pathway. So all the cell lines are blocked in urticaria. So we might get a cure in urticaria. This is the in nutshell my presentation. Thank you.
Any question? Any question from the audience? Thank you, madam.
Thank you so much, ma'am, for wonderful session. I would kindly request our chairpersons and speaker to kindly collect their mementos. For next session, I would kindly request Dr. MP Chaudhary sir and Dr. Punkesh Kumar sir to chair the next session.
Hello, I invite Dr. Prakriti Malhotra, Senior Resident, MGM Medical College, Jamshedpur.
Thank you, sir. So, good afternoon, my respected chairpersons, seniors, colleagues, and my dear juniors. I'm Dr. Prakriti Malhotra, and at the outset, I would like to sincerely thank the organizing and the scientific committee of Mid-Clinicon 2026 for giving me this opportunity to speak on such an exciting topic, that is GLP-1 receptor agonist in dermatology. So, over the next 15 minutes, we shall together explore So over the next 15 minutes, we shall together explore the expanding therapeutic horizon of GLP-1 receptor agonists in the field of dermatology. So what is this GLP-1? This GLP-1 is nothing but an endogenous incretin hormone which is produced by our intestinal L cell and is responsible for regulating the blood glucose level by stimulating insulin secretion and suppressing glucagon secretion from following a meal intake. And it also helps in reducing the appetite by acting at the level of hypothalamus by activating the satiety center and also by delaying the gastric emptying. And these GLP receptor agonists are nothing but peptide analogs that mimic the structure and action of endogenous GLP, structurally modified to resist the DPP-4 degradation, thereby prolonging the half-life. So they're currently approved for the treatment of type 2 diabetes mellitus and obesity, and they're widely recognized by the names of Ozempic and Mounjaro by the lay people. So within this class of drugs, we have several drugs. We have the oldest one, exenatide. We have liraglutide, the once weekly injectable dulaglutide and semaglutide. We also now have oral semaglutide, which was approved in the year 2019 for the treatment of type 2 diabetes mellitus. And the new kid in town is tirzepatide, which is actually a dual GLP-1 receptor and GIP agonist. And retatrutide is now the first triple receptor agonist, which is still under investigation. Recently, in year 2026, for chronic weight management, Foundayo by Eli Lilly, orforglipron was approved, which is the first non-peptide oral small molecule GLP-1 receptor agonist. Now, the question is, why are we talking about this drug, which is traditionally used by endocrinologists, into the field of dermatology? First and the foremost, we know that obesity, which is a chronic low-grade inflammatory state, and it is driven by a number of pro-inflammatory cytokines and leptins. And that kind of inflammation can initiate and even exacerbate a number of immune-mediated skin disorders, notably psoriasis and hidradenitis suppurativa. At the same time, there are multiple dermatological conditions which are closely associated with insulin resistance and metabolic syndrome. Although these GLP-1 receptors are found to be expressed in skin in a number of murine studies and human skin studies, especially around the hair follicle, within the keratinocytes, and even within the infiltrating immune cells within the psoriatic plaque, their role is not fully understood. And third, but the most important, beyond the glycemic control and weight loss, these drugs have shown to exert direct anti-inflammatory effect by suppressing key cytokines, your interleukin 17, 23, TNF-alpha, and modulate several intracellular signaling pathways which are there, which are central to the pathogenesis of number of immune-mediated skin disorders, so that GLP-1 receptors may even improve cutaneous inflammation. So coming on to what dermatoses have emerging evidence for GLP-1 receptor agonists. So in my research, with what I found was the evidence is still very limited and fresh, but from the limited evidence that we have, the most evidence we have is for psoriasis, followed by hidradenitis suppurativa, with few occasional observational and preclinical studies pertaining to wound healing, and some dermatoses have isolated case reports which have shown encouraging results. So coming on to why are we talking about GLP-1 receptors in psoriasis when we already have a huge armamentarium of number of effective biologics. Now we know that psoriasis is a prototypical immunometabolic disease with high prevalence of obesity, metabolic syndrome, and non-alcoholic fatty liver disease. And obesity in psoriasis as a fact is known to be associated with higher PASI scores, reduced response to therapeutics, and even increased relapse rates. And the major cause of mortality in psoriasis, as we all know, is due to cardiovascular disease, and these drugs in clinical trial have shown to reduce the cardiovascular risk factors. So this here summarizes all the immunological mechanisms by which GLP-1 receptors may improve psoriasis. While the biological mechanisms are very compelling, but the ultimate test is the clinical efficacy. So that's what I aim to bring to your notice. Now here in a glance, this is all the evidence that I could sum up in a single slide. It ranges from case reports from one end of the spectrum to two meta-analysis, and much of the earlier studies were actually done with liraglutide, and the newer molecules like semaglutide and tirzepatide, the evidence is now beginning to emerge. Sorry, the key findings, if you look at it taken together, you can see that there is a significant PASI reduction with all these GLP-1 receptors along with the improvement in DLQI. So coming on to the meta-analysis. Now Chang et al. In 2026 pooled 4 studies, 1 RCT and 3 cohort studies, including 32 patients with psoriasis with type 2 diabetes mellitus receiving liraglutide. They showed significant PASI reduction in those patients. But what is interesting to note is that there was no significant difference in BMI or HbA1c, which tells us that this clinical improvement actually occurred. It may be independent of the weight loss, and there may be other factors which are in play. Further, Ko and Chang expanded that evidence base to include 6 studies, 2 RCTs and 4 cohort studies, and including double the number of patients, and they also showed significant PASI reduction with 35% of the patient achieving PASI 75, and these benefits were observed in both type 2 diabetes mellitus and obesity patients. Although the limitation was there was heterogeneity amongst the various studies within this meta-analysis. So coming on to these individual studies, so the recent study actually is in 2025. It was an open label RCT in psoriasis with obesity and type 2 diabetes mellitus. Semaglutide was evaluated in the in one arm, and the other arm was receiving just metformin. And this also showed 46% of the patients achieving PASI 90, with 8% even showing complete clearance and significant improvement in DLQI in the semaglutide arm. Similarly, Shu et al. In a prospective cohort study studying liraglutide demonstrated significant reduction in PASI, DLQI, and even epidermal thickness. And similar case reports have also shown encouraging results. In fact, as early as 2012, the first case report, which actually where exenatide was added for diabetes mellitus, it showed that there was relapse after discontinuation of exenatide, and once it was reinitiated, there was improvement in psoriasis. So, but the evidence is not one-sided. The first RCT, which was done for GLP-1, which was a placebo-controlled double-blinded RCT, demonstrated no significant improvement in PASI or DLQI with liraglutide versus placebo in glucose-tolerant obese adults with chronic plaque psoriasis. And in additionally, there are isolated case reports which have shown paradoxical exacerbation of psoriasis following liraglutide, and more recently in one of the JAD publications, tirzepatide. So these findings tell us that the current evidence base is still evolving, and we need to have good multicentric RCTs before we can draw definitive conclusions. So these are the ongoing trials. One of them has been recently concluded by Eli Lilly Together SOAR trial, where they've studied adding tirzepatide to ixekizumab, and they have seen in moderate to severe plaque psoriasis in obese patients, adding this combination improved complete skin clearance and produced greater weight loss versus just giving ixekizumab alone. Similarly, semaglutide has also been studied, is being currently studied in an open label single-arm pilot trial, and the results are awaited. So the take-home message, if there's one thing I want you to remember, it has shown promising efficacy, particularly in patients with metabolic dysfunction. Its role is currently just adjunctive, but despite encouraging clinical outcomes, there are a lot of problems, variability in study design, treatment regimens, small sample size, short follow-ups, which limit the strength of current evidence. So we need larger multicentric randomized controlled trials before we can clinically adopt it into our practice. So coming on to the next inflammatory dermatosis, which is generating significant interest, which is hidradenitis suppurativa. Now we know the rationale here is quite compelling. HS is strongly associated with obesity and various metabolic dysfunctions. So GLP-1 receptors, by reducing the body weight, it will reduce the skin fold friction and mechanical stress. It will reduce the insulin resistance, and also it will bring down the systemic inflammation by inhibiting various inflammatory cytokines. Again, if you look at the evidence, remember that unlike psoriasis, in hidradenitis suppurativa, we do not have any randomized controlled trial yet, But we do have 2 systematic reviews published this year itself, and they have shown significant improvement in all the parameters, be it severity or DLQI, metabolic parameters, and even healthcare utilization. Similarly, semaglutide has also shown to be associated with lower healthcare utilization when we are using it in hidradenitis suppurativa patients. So the key take-home message is, again, it is a promising adjunctive therapy at best, particularly in patients who have a metabolic indication. Remember that the evidence still remains observational with no completed RCTs, underscoring the need for well-designed trials, and we need larger trials to separate its direct immunomodulatory effect from its indirect metabolic effects. So other than all these inflammatory dermatoses, these drugs have also shown to have a promising role in wound healing. Mechanistically speaking, in various animal studies, it has shown enhanced keratinocyte migration, angiogenesis, and even reduced oxidative stress. And in various observational studies, it has shown improved outcomes in diabetic foot ulcers and venous ulcers. Again, this is an emerging area, not an established indication, since we do not have any completed RCTs yet. But what is more exciting is the growing evidence for other dermatoses in the field of usage of GLP-1 receptor agonists in dermatology. We have isolated case reports in showing improvement and encouraging results in Hayran syndrome, Hailey-Hailey disease, folliculitis decalvans, acne keloidalis nucae, some observational studies even in atopic dermatitis, and 2 case reports which showed improvement in refractory chronic spontaneous urticaria. However, the evidence currently is still very hypothesis generating because we do not have better quality evidence. So coming on to safety profile, these drugs are generally very well tolerated. Only problem is the GI disturbances, which is usually dose dependent. It becomes better with time, and you tend to get these effects when the patient starts the treatment or when the dose is escalated. But what is clinically more important are the less frequent adverse effects, notably your cholelithiasis, cholecystitis, the dreaded pancreatitis, and even the worsening of diabetic retinopathy, which is seen with patients who have achieving rapid glycemic improvement. Hypoglycemia is not a major concern with it, but if you combine it with secretagogues, then that becomes relevant. And what is particularly important is telling our patients to take a good protein diet, because sarcopenia is associated with GLP-1 receptor agonists. But beyond these systemic adverse effects, please, if this is a very important slide, the cutaneous adverse effects, which we must know that GLP-1 receptors have been reported with. So the most common being injection site reaction, pruritus, erythema, rash and nodules have been reported, urticaria, angioedema, anaphylaxis, and even isolated case reports of bullous pemphigoid, leukocytoclastic vasculitis, eosinophilic fasciitis, panniculitis, and due to rapid weight loss, even hair loss, telogen effluvium has been reported, and oral semaglutide is associated with altered skin sensations. But what is important is this growing aesthetic concern, so-called Ozempic facies, which refers to facial volume loss and skin laxity and hollowing due to rapid weight loss, and it's due to rapid weight loss and not a direct adverse effect of the GLP-1 receptor agonist. So these are the key take-home message. I'll conclude with this. Thank you so much for your patient listening. I hope you enjoyed it as much as I enjoyed making the slides. These were my references. Thank you.
Thank you so much. Any question from the house? Thank you. Thank you so much, Dr. Prakriti.
upon our stage our President, Patron, Dr. P.K. Roy sir, to kindly join us, our Organizing Chairperson, Dr. Sudhanshu Singh sir, our Scientific Chief Advisor, Dr. Ravi Vikram Singh sir, our Secretary ACDI, Dr. Abhishek Kumar Jha sir, our Scientific Chairperson, Dr. Vikas Shankar sir, our Scientific Co-Chair, Dr. Swetalina Pradhan ma'am and Dr. Anupam Das sir, our Organizing Co-Chairperson, Dr. P.P. Prabhakar sir, our Organizing Secretary, Dr. Punkesh Kumar sir, our Treasurer, Dr. R.R. Madhukar sir, our Organizing Joint Secretary, Dr. Rajnish Kumar sir, our Scientific Joint Secretary, Dr. Shivani Shekher, to kindly join us on the stage.
किसको दिलवाए पहले अवार्ड पेपर दिलवा है पीछे बैठे लग रहा है. I'll request all the PGs to kindly come in the front who are having lunch.
The PGs will be coming here who has won the prizes in the PG quiz. All the PGs should come in front. There's nothing, no scientific session, so don't...
All the PGs who have participated in any of the programs like quiz, award paper, poster, kindly come up.
Award paper दे दिया था, award paper तो दे दिया था.
Sir,
Don't worry about the scientific, we are not going to ask you any questions and all, you can come and join us. At least say thank you very much. You have to say thank you for organizing this kind of conference.
So we have the quiz results with us, which happened today morning.
So ladies and gentlemen, this is the last and this is the final, this is valedictory function where you are supposed to judge us. How have you fared? I mean, अपनी पीठ तो हम तब सपा लेंगे कि बहुत अच्छा किया, बहुत अच्छा किया. लेकिन the people sitting here like Kripa Shankar, I mean, he wants to say something about this organization of this conference and all. He is welcome to say his few words to encourage us to have more and more this kind of session and this kind of this thing. So other people also, if you want to say you something, otherwise मैं तो सबको बाद में thank you कर ही दूँगा.
Good afternoon, everybody. I think first and foremost, this has been an extremely well put together conference, and a conference focusing exclusively on the clinical aspects of dermatology was long in the coming, and it is very important to us. We are all very attracted towards procedural dermatology. In fact, there are conferences on procedural dermatology, which I fully understand. Having said that, I thank Dr. P.K. Roy and his team and every one of you who are here on stage and many of you who are off stage who have been responsible for conducting this conference, for bringing this conference along. And there are a couple of things I would like to say. When I was looking carefully at the panel discussions, I think the panel discussions require a little more depth, in the sense that people are falling a little far behind on the evidence. Like for example, in the case of vitiligo, after 4 decades of studying vitiligo, Professor Nordland made one significant, most important, central, crucial finding, that the vitiligo skin is actually less cancer prone than the melanized skin. So actually that was directly contradicted. These are the kind of things that we need to bear in mind, where we can afford to take a liberty with vitiligo skin in terms of aggressive treatment. Having said that, I would say this is a good attempt, and Dr. P.K. Roy and his team have put together this conference extremely well. And of course, this is also an occasion for us to very, very fondly remember Dr. Amarkant Jha Amar, who was a friend of mine for several decades. I first met him when he had put the constitution of the IADVL together. I picked up my first copy of the constitution from him when it was first published. So from an emotional point of view too, this has been extremely satisfying. And I also wish greater and greater success to future versions of this conference. And I would like to close by assuring that whenever this is held, I'll be there. Thank you all very much.
Thank you, Dhiran, and thank you, Kripa. And I hope that we'll meet more often now. So you will be a permanent guest of ours, and please be the thing. Any more people? Any more person from the audience? Okay, then let me thank you. Let me ask people from outside. Dr. Anupam. So he is part of Bihari family now, and he is part of Clinicon and Cuticon, everything. But let him say a few words. Let's hear from you, Anupam. How did you like it?
At the outset, thank you, Abhishek sir. तो जब भी अभिषेक सर का फ़ोन आता है मे बी मॉर्निंग इवनिंग सर जस्ट स्टार्ट्स बाय सेइंग क्या अनुपम भाई क्या हाल है सो देन आई अंडरस्टैंड कि कुछ आ रहा है टास्क मे बी सम कॉन्फ्रेंस सम मे बी वेबिनार सम बुक मतलब कुछ तो काम आ रहा है अभी तो ये डेट ब्लॉक कर लो आपको आना है हमारे साथ रहना है काम करना है सो whenever Abhishek sir is inviting, no question of saying no. And of course, I think I'm one person who is not a part of IDVL Bihar, but who has attended the maximum events of Bihar, be it IDVL or be it ACDI. Thank you for having me. It's always a pleasure to be a part of this family. Special thanks to Vikas sir, Swetalina, PK Roy sir, Ravi, Vikram sir, everyone who is on the stage. Thank you for having me.
Over to Abhishek Jha for connecting more this thing. Abhishek Jha. Take over the.
Good afternoon, everyone. So we will start with the award paper. So third prize goes to Dr. Sneha. Dr. Sneha. She's from ANMCS Gaya. So they have been given the gold medal. Now we are giving the certificates and the memento. And the second prize, Dr. Jayashruti from NMCS Gaya. May I request the HOD of Gaya Medical College, PP Prabhakar sir, to join. Sir, sir, sir. And the first prize goes to Dr. Devanshu from PMCH.
अभी क्विज है क्विज और पोस्टर
And we had a quiz this morning, and the third prize goes to Team IGIMS, Dr. Shivani and Dr. Nikhil Sharma. And the second prize goes to team NMCS, Dr. Shivam Bansal and Dr. Rashmi. May I request Dr. Vikas Shankar to join? NMCH. और तालियां बजनी चाहिए पीएमसीएच टीम के लिए. डॉक्टर सौम्या एंड डॉक्टर भाविनी, द फर्स्ट प्राइज, टीम पीएमसीएच.
I request their teacher, Dr. Abhishek Kumar sir, to kindly join. नहीं सर, last. And for the posters, the third prize goes to Dr. Anugya from NMCH. And the second prize goes to Dr. Sujata from PMCH. And the first prize goes to Aparna, Dr. Aparna from PMCH. She's not here? खुश रहो यही ले लेगी ना सुजाता, ले लो तो अपर्णा का ले लो जाके ले लो अपर्णा का. And we have started something new this year. This is the rising star in dermatology, the young star. And due to her work in dermatology and her
contributions in many conferences, many CMEs. She has single-handedly conducted many CMEs and conferences also. This goes to Dr. Aditi Snehal this year. तालियां बजे इनके लिए एक बार. May I request our President, Dr. P.P. Prabhakar sir and Dr. Ravi Vikram sir and Dr. Vikas Shankar. इसमें कोई है कहाँ जिसको इन्फॉर्म कर I will request everyone to stay and for this conference, for their contribution, I would like to present the mementos to the people behind the scene who have helped us. Mr. Abhishek Roshan. I request our President. नहीं है. Thank you. May I request Mr. Sumit to receive the Appreciation Award on behalf of Mr. Sanjay Sharma from Dharma Joint. I request our President to... Sir, आप खड़े रहिए. And I thank Dharma Joint. May I request Mr. Naveen from GSK. आपके बॉस नहीं है तो बुलाइए. May I request Mr. Raja Adhikari in इसी कॉन्फ्रेंस में अगर ये जो हमारे राजा भाई फारूक जी, नदीम जी और मुदस्सर नसीर जी ये लोग नहीं रहे तो फिर ये कॉन्फ्रेंस मुझे लगता है कि होगा ही नहीं मुझसे. तो ये हमारे बैकबोन है इनफैक्ट. थैंक यू सर. आप भी मुझे नहीं पता था आप आने वाले हो, अदरवाइज मैंने बना दिया नवीन का, आपका मैं अलग से बना के दे दूँगा. जीएसके वाला दीजिए, इनका एक नाम नोट करके इनका बना के दे दीजिए. जीएसके आइए. अच्छा फोटो. हाँ हाँ मैं रिक्वेस्ट करूंगा अभिषेक जी को कि मिस्टर बीडी सिंह के बिहाफ पे अप्रिसिएशन अवार्ड ग्रहण करें. I request Mr. Mohammad Mudassir Munir. डॉक्टर स्मिता प्रसाद, आइए। The President wants to appreciate you. ये अपर्णा वाला मेडल वापस आ सकता है किसके पास है?
Please bring forward the first prize of poster.
अब मैं फारूक जी को रिक्वेस्ट करूंगा कि ऊपर आए। अभी क्लिनिकॉन नेक्स्ट कहाँ होगा ये तो पूरी तरह से फाइनल नहीं है। शिमला, धर्मशाला और आसपास की जगहों पे हम लोग देख रहे हैं, लेकिन अगला सेकेंड मिड क्लिनिकॉन कटिहार और पूर्णिया में होगा और डॉक्टर शिवा हुसैन जो HOD हैं, डर्मेटोलॉजी हेड हैं वहाँ पे KMCH की, वही करेंगे। सो आई वेलकम यू ऑल, इनवाइट यू ऑल। साथ ही हम 30-31 अक्टूबर और 1 नवंबर को क्यूटिकॉन कर रहे हैं गया में। तो जो भी हमारे लोग आए हैं बाहर से और जो आप लोग हैं, मैं सबसे आग्रह करूंगा कि उसमें आप लोग जरूर आएँ। धन्यवाद।
Thank you everyone. I would request you to kindly proceed for the lunch.
राजा भाई कहाँ हैं? राजा जी,